Hello, everyone, and I'd like to welcome everyone to the ACPMP 2021 Appendiceal Cancer Survivorship Symposium. I'm going to see if I can share my screen. Welcome, welcome, welcome. On behalf of myself, the ACPMP, supported by three institutions, Wake Forest Baptist, or Wake Forest Atrium as we're now called, on the East Coast, University of Chicago in the Midwest, University of Utah Huntsman Cancer Institute, and the western part of the country. There we go. So welcome, welcome, welcome. I think we have a whole lot to talk about. We have some great sessions. The day is broken into two parts. The combined session from all three of these comprehensive cancer centers, and then local sessions headed from each of the three universities which are leading this program. And at the very outset, again, I want to thank the ACPMP for sponsoring this very important symposium. I'm Dr. Ed Levine, coming to you from beautiful Winston-Salem in North Carolina at Wake Forest. And I'd like to start out with my first talk. We're going to be talking about this. Some of this is an introduction to where you are and what you've got. And for the appendiceal cancer patients, and I've been privileged to treat about 1,000, the most important thing I'd like to get across is that you are not alone. And while this is a rare tumor, and you patients with appendiceal cancer are literally 1 in a million, you have an opportunity today, at least virtually, to meet with and interface with a whole host of other patients who are facing what you're facing today. Some of whom I know were diagnosed literally last week. Others are long-term survivors who are more than 20 years out. Also, a great welcome to all the caregivers who are helping all of our patients move forward through this challenge. Now, it's no surprise to say that appendiceal cancer is indeed a rare tumor. This gives you a rough idea of how common these tumors are and are not. So there's 250,000 lung cancers, close to 300,000 breast cancers, 150,000 colon cancers, on down the list. Appendix cancer is somewhere in the range of 3,000 cases a year in the United States. Now, research monies are allocated by the National Institutes of Health and the National Cancer Institute based on incidence. So up until very recently, the only real source of research grants for appendiceal cancer research was the ACPMP. And I'm proud to say we have now been awarded here at Wake Forest, led by partner Dr. Votanopoulos, the first major research grant award for several millions of dollars for cancer of the appendix. This has come from the ongoing efforts from the ACPMP and others who have supported a lot of the research efforts which have gone forward to date with their philanthropy. So please keep that in mind. Now let's talk a little bit about exactly what you're facing in terms of appendiceal cancer. And first I'm going to talk about appendectomy. Most people know a little bit about appendectomy. It's hard to have somebody who doesn't know somebody who's had one. And there's close to 500,000 appendectomies performed a year in the United States. A tumor is found in those appendectomy specimens in about 1% of those cases. And these can be benign tumors, malignant tumors. There's actually a whole host, and I'll show you some of what these things can be in just a minute. Cancer of the appendix was first reported in 1903. So this is not really a new problem, but the magnitude of the problem has only been appreciated much more recently. Less than half the time, even with current CAT scanners and MRI scanners, do people expect or surgeons expect to find a tumor when they're operating on patients for cancer of the appendix. Appendiceal tumors represents no more than 0.5% of all GI malignancies. So they're almost always incidental finding. And elective appendectomy, knowing you're operating on a tumor of the appendix ahead of time, is essentially an unusual event. Frankly, I've got a practice which is hopelessly enriched in appendiceal cancer patients, and I'll do 2 or 3 such cases a year. Now, these tumors can be either benign or malignant. There's about 10,000 benign cases a year in the United States. They're slightly more common than the malignant ones. Most are incidental. And the ones that are probably going to be of most interest to us today are what we call the Lambert and Hammond tumors. Now, what the heck is that? Lambert stands for low-grade appendiceal mucinous neoplasm. And its nastier older brother is Hammond, or high-grade appendiceal mucinous neoplasm. These are pre-invasive tumors, but they have the nasty habit to progress and rupture, and they can lead to the pseudomyxoma syndromes. And I'll tell you more about that in just a minute. And there's a host of a variety of benign tumors of the appendix, which are relatively rare and don't really progress to anything, for which a simple appendectomy, just taking the appendix out, is curative. And now let's talk about the beast, which is malignant appendiceal tumors. Now, there are different types of appendiceal tumors. As rare as appendiceal cancer is, there are several different subtypes. Carcinoid is the one that used to be thought of as most common. I think the more common or more up-to-date is the adenocarcinomas and the appendiceal mucinous neoplasms are probably more than half of them now. And there are a whole host of descriptors that pathologists use to describe the different adenocarcinomas. There's mucinous, low-grade, high-grade, adenocarcinoid, manic tumors, goblet cell, signet ring, et cetera, et cetera. The pathology descriptors are confusing, and they're changing. The World Health Organization recently came out with an additional, what they call fascicle on appendiceal tumors. And how pathologists are supposed to describe this has changed. Unfortunately, not all pathologists use the World Health Organization criteria. So understanding this, you need to talk to somebody who really knows what they're dealing with, to know the nuances between the different types of the appendiceal cancer. A question I'm frequently asked is, but I just had a colonoscopy. They didn't see anything. Why is that? And this is a series we put out a few years ago. And what we found is that we looked at all the patients who came in with advanced appendiceal cancer. Of 191 patients we looked at, about a third of them had preoperative colonoscopy within a few months, and only 3% of those cases were discovered by colonoscopy, 3%. And it's because the appendix tends to hang off of the side of the colon, and the colonoscopists or the GI doctors who are doing this have a hard time seeing it. I don't think it's a failure of the GI doctors as much as a failure of the technology. The other issue is that close to 40% of these patients had additional polyps found in the colon. And what that tells you is if you have one of these tumors found at the time of an appendectomy, before you have definitive surgery, it's important to have a colonoscopy because there's a reasonable chance there could be something else going on in the colon at the same time, a second primary tumor. Now, I'm going to show you some pictures. So if you have younger, more sensitive viewers in the audience, close your eyes at this point, at least for a minute. And I'm going to talk a little bit about pseudomyxoma. What the heck is it? You'll hear about that a lot. This is an entity which was described in 1884. And although it has a number of different monikers, what it really is mucinous ascites. Ascites is fluid in the abdomen. Mucinous ascites is mucinous fluid in the abdomen. The vast majority of these come from the appendix. They can come from other sources occasionally. Occasionally we'll see them from the ovary, rarely from the cecum, occasionally from unusual pancreatic tumors or other rare tumors, but the vast majority are really going to come from appendiceal tumors. And they're called pseudomyxoma or false mucin, which is actually not a good name because it is a true mucin. It's just not what they thought of. These tend to be low grade, but they are not all low grade. These can come from low grade or high grade tumors. And unfortunately, the 5-year survival rate left untreated is poor, only about 10%. Now, taking the mucin out can be very helpful. It can substantially diminish symptoms for a while. But removing the mucin is never curative. What you want to remove is the tumor cells that are producing that mucin. That's the trick. Now, these appendiceal tumors are increasing in incidence. You've got two studies here, and both showing exactly the same thing. So between 1970 and 2010, this has increased 2.5-fold in terms of the number of cases found. And much of this was in after the turn of the century. Now, why that is, it's not clear. I think pathologists, to some measure, are doing a better job at diagnosing. I think a lot of these were misdiagnosed as other types of tumors in the past. But this is becoming a more common entity than it used to be, rare as it is. Now, I'm only going to talk briefly about carcinoid tumors. This is about 40% of all carcinoids come in the appendix. You can get carcinoids anywhere in the GI tract and actually in the lungs as well. Most of them are in the distal tip, which means they rarely cause obstruction. There are tumor markers or blood tests which can be helpful, which are not as helpful for other tumor types. They're commonly associated with second primary tumors, and the prognosis is clearly related to size. Of note, carcinoid tumors never lead to the pseudomyxoma syndromes. Never. They do not make mucin. Now, these patients are, even if the tumor spreads, good candidates for cytoreductive surgery, but HI PEC is much less effective than it is for other tumor types. And there's recently been some substantial improvements in the systemic therapy for this. And I'm not really going to talk anymore about carcinoid tumors. The real focus are the appendiceal tumors. And most patients like to know, well, is there anybody famous who's had this disease before? And here's a couple of people that are, and this is two of the most famous ones, I think. One first is Audrey Hepburn, who got this at age, I think, 63, and Stuart Scott, who died at age 50. Stuart Scott was a sportscaster who's got actually a great quote that I hope you can see on the right lower quadrant of your screen there. If there's any surgeons in the audience, let's say if you find an adenocarcinoma of the appendix, please document what you see. Look around, but you do not have to do definitive tumor resections at that time. Patients are usually not consented for it because you usually find this at the time of an appendectomy. Biopsy it, take out the appendix if it's perforated or you have to, and then get the patient to an experienced center is what needs to happen. Again, we talked about the variety of histologies, which this can be, and unfortunately, when appendiceal cancer is found, it is usually found in a metastatic state with tumor which is spread through the peritoneal cavity. So 2,500, 3,000 cases a year of these mucinous appendiceal tumors. They're usually found ruptured. Again, second primaries are common from the data I showed you previously. There are blood tests which are useful. CEA levels, CEA 19-9, CEA-125. Now, those are tumor marks. CEA is used for any GI tumor. CEA 19-9 is a foregut cancer, usually for esophagus and gastric and pancreas cancers. Also useful for these tumors for peritoneal metastasis. CEA-125 is classically an ovarian cancer marker, also used for patients with appendiceal cancer once it's spread to the peritoneal cavity. Now, on the horizon are liquid biopsies. You're going to be hearing more about that later in an upcoming talk later in the morning. I don't want to talk about that, but that's clearly got some potential for patients with cancer of the appendix. For patients with adenocarcinoma of the appendix, the prognosis is clearly very closely associated with grade. The risk of nodal disease is very closely related to grade, and the prognosis, even if the tumor has spread to the peritoneal surfaces, is also related to the nodal status. So you want to know if the tumor is spread to the lymph nodes and for the higher grade tumors. Beware the several pathologic descriptors. Signet ring cell, aggressive, poorly differentiated, goblet cell, adenocarcinoma. You can see all these terms thrown around. Most pathologists are going to see one or two of these in a year. Unless you're coming to a specialized center where you see a lot of these, or you have an experienced pathologist review the specimen that was removed at the time of any surgery, you can be misled a little bit. In general, if the tumor is high grade, we usually add a right colectomy. If it's low grade and the margins are negative, we just take out the appendix. You don't necessarily always have to remove the right colon for the low grade tumors. Frankly, if the tumor is unruptured in the appendix and the margins are negative, a simple appendectomy is curative. We just did a study, and this was a paper that came out a few weeks ago, quite frankly, looking at the operative reports for general surgeons who do appendectomies. We looked at 490 reports for cases that we had treated here at Wake Forest, all of whom were incidental. So all the patients were operated on for what they thought was appendicitis. And while 80% met the technical requirements for reporting an operative report, 44% made no comments at all about whether there was anything in the peritoneum. Now, these are patients who have got widespread peritoneal metastasis. 48% had only a partial view, and only a handful, 7%, had a complete evaluation where they actually turn the scope when they're doing, and most of these are done laparoscopically nowadays, around to survey the rest of the abdomen to see where the tumor is and isn't. And this has led us to embark on an education effort for general surgeons to help them document, because it's going to make a large difference to future appendiceal cancer patients to know exactly where the tumor is and isn't, to avoid repeat laparoscopic explorations, unwarranted things. And the other thing we found is that 15 to 30% of the pathology reports were not correct when compared to the final reports. And a lot of this is related to pathologists who are not used to seeing this type of unusual tumor, generating some reports which make misclassify something as low grade as to high grade as to low grade, et cetera, all of which has substantial impact on the treatment plan for the patients. So let's talk a little bit about grading, because for appendiceal cancer, these mucinous tumors, the histologic grade is really important. The original descriptor of this was written by Dr. Ranette, who was a pathologist at Johns Hopkins who worked with Dr. Sugarbaker, and she came up with a 3-tier system. Here at Wake Forest, the Memorial Sloan Kettering, several other places use a 2-tier system, low grade versus high grade. The worst actors are signet ring and goblet cell cancers. Now, signet rings, you have to be careful. There are specific rules for what percentage of the tumor has to have signet rings in it. I've seen many patients labeled as signet ring when a pathologist says, well, potential suggestive signs of signet ring features. If they're not definitive signet rings in significant numbers, that doesn't qualify as a signet ring cancer, and the prognosis is difficult. As I said before, there is a WHO, that's World Health Organization, and a fascicle is basically a pamphlet in terms of how these things should be agreed to. This was agreed by the World Health Organization, which is supported by the United Nations, of all things. Having said that, not all pathologists subscribe to it or use it, which leads to all sorts of confusing descriptors and changing rules. Now, the bad news is the older literature you read, the worse and more complicated this becomes, because it was the fascicles before were even worse, and there was less adherence to rules for dealing with things. Now, I'm just going to show you some pictures of what these cells look like under the microscope. What you see here is a low-grade tumor. So on the right side of your screen, that's mucin. At the edge of what looks like the whitish area, there are a handful of cells. I'm going to see if I can point to this with the pointer right here. I hope you can see the pointer at home. Those are the cells. That little amount of cells, that's what's producing all the mucin. And those cells are producing underneath them, this is all sclerotic fibrous tissue. So around these handful of cells is a large fibrous sclerotic core. The actual tumors, if you see them, are not soft and mushy like mucin. They're actually hard as leather. But you're seeing just a handful of cells causing a great deal of trouble. And that leads to some of the problems with some patients having no cells seen in large mucin pools. That doesn't mean they're being produced by nothing. That just means you didn't find this small number of cells which are producing the problem. This is more of an intermediate grade, and you're seeing some other things here. Now the number of cells, some of these cells are infiltrating into these little cords between the mucin pools. And this whitish material here, that's what mucin looks like under the microscope. And you see a few of these cells are actually starting to break off and float away in the mucin pools. So that's what defines an intermediate grade. And this is a high-grade tumor. Again, you see more cells, which is little circular things out here, in these little cords out here in between. And now you got lots and lots of these cells. These are cancer and tumor cells floating away in the mucin to cause havoc in other places. And that's what the pathologists are looking for when they classify these tumors. Why is this important? What you see on the screen is 3 different survival curves from 3 different organizations looking at histologic grade and outcome. And for each one of them, and these are somewhere between 5 and 15, 20-year survival rates, G1 is low grade, G2 is high grade, G3 is very high grade for those that you'll see. And you can see the differences in survival. Most of the patients with low-grade tumors are going to be long-term survivors. And the prognosis of the intermediate grade and the high-grade tumors is substantially worse. So we can prognosticate very crisply on what the pathologist reviews. But I want to point this out again. An expert pathologic opinion in the tissue that's been removed to assign the grade is crucial, because much of the therapies are going to be based on that grading. Now, not all appendiceal tumors are created equal. Even with the plethora of clinical markers, some patients still do poorly, even with relatively low-grade tumors. Now, at the top of the screen, I've listed many of the prognostic features that we see. These are a whole handful of things: grade, stage, completeness of resection score, nodal status, experience of the team, experience of the surgeon, intraperitoneal therapy, ascites, comorbidities the patients may have, et cetera, et cetera. I wanted to look beyond that, and several of the institutions have. And what I'm showing you here, the word of the day is dendrogram. And the picture on the left side of the screen is a dendrogram, which is looking at how these different tumors, each one of those little dashes on there is a specific gene. And this is the first study that I know of that was done looking at appendiceal and colon cancers, looking at the different genes that are active. So instead of just looking at the cells under the microscope, we're now picking them apart and figuring out what part of the DNA is active. And on the right side of the screen, the green line at the top, those are low-grade appendiceal tumors with favorable histology. So if the genetics are favorable, that's what you're going to get. The other ones are going to be colon cancer or high-grade appendiceal cancer, the other line. And what did we find from this very first investigation, looking at appendix cancer, is that appendix cancer is very different than colon cancer. We then did additional analysis on this. We can actually tell you what type of mutations they have. We looked at the whole, what they call whole exome sequencing, which means looking at all the DNA that the patient has in these cells. And there's close to 40,000 genes in the human genome. So this is a whole lot of DNA sequencing. And this is again, a complicated map. I don't expect you to be able to read this. We have a list of some of the most common mutations here. And these are the different types of mutations. And those are things that you have a DNA base has been replaced. The DNA base is missing. There's a code in the DNA code which tells the DNA to stop making proteins, start making proteins, end the sequence. So we know a whole lot about what the mutations are. And it also tells you that the number of mutations that we have here tends to be very low. And I'll tell you why that's important in just a minute. And that was work that was done here at Wake Forest. Other centers have done sort of the same thing. There's 2 large houses which do what they call precision medicine or next generation sequencing. And this is a series of 700 patients who had next generation sequencing. That looks at several hundred genes, not all the genes. And what did they find? The most common genes that are mutated are 2 called KRAS and GNAS. There's some other ones which are somewhat prognostic. And what did they find? They found that the mutation profiles of appendix cancer are different than colon cancer. This is a very similar study of a smaller number of patients. And in this study, they had 224 patients with appendiceal cancer. And what did they find? The total mutation burden is low. Microsatellite instability is low, and those are important to predict who's going to respond to some of the newer checkpoint inhibitors. And the mutation profiles are, again, very different from the colon cancers. Now, that's important because in what you see at the bottom is an next generation sequencing report that we got from one of my patients. And it basically, what it says is there's no mutational burden in here. and there are no targets. And unfortunately, that is what most patients with appendiceal cancer are going to get when they get these next generation sequencing reports. That doesn't mean they're not worth to do them. What it does mean is that very few of these patients, less than 5%, are going to have an actionable mutation. From all this genomics, what have we learned so far? Appendix cancer is not the same as colon cancer. And that's important because all the chemotherapy for appendix cancer is based upon colon cancer, and that is unfounded. Genomics are clearly here to stay. You're going to be hearing more and more about these, again, later in the talk. So what are your options for treatment? Chemotherapy, immunotherapy, which unfortunately is rarely useful, radiation therapy. I'm going to tell you not to do that. People have tried shunts to try to shunt the mucin out of anywhere. Definitely don't do that. Conventional surgery, cytoreductive surgery, and HI PEC. And for some patients who aren't candidate for any of that, there's always palliative care and hospice. That's not something we like to resort to. Now, the chemotherapy response rate, and this is a study which was done with us at Wake Forest and MD Anderson years ago, the actual response rate was only 8% to conventional chemotherapy. So these tumors aren't super responsive to chemotherapy. Now, some of the high-grade ones are. The systemic therapy progression-free survival was better for high-grade tumors. Overall survival was better for high-grade tumors if you did get some chemotherapy, not statistically significant. But systemic chemotherapy is not curative of this disease. I don't know of a single case that's clearly been cured with chemotherapy, although as the chemotherapy gets better, that's going to happen sooner or later. They're best for high grade. They have extremely limited utility for low grade. And for patients with pseudomyxoma, stable disease is the goal of treatment, not to have the tumor shrink. Now, cytoreductive surgery and HI PEC is something I believe almost everybody tuned into this is going to be familiar with. The goal is to remove, you have a disease where there's got extensive peritoneal metastasis, and we want to use aggressive peritoneal therapy. This is delivering chemotherapy into a field with the abdomen opened up and all the scars and adhesions taken down after the tumor has been removed. So the HI PEC is delivered typically after all the surgery has been done. This can avoid what they call EPIC or additional ports for intraperitoneal chemotherapy given in a postoperative period. It's usually delivered with some moderate hyperthermia, which helps the chemo work better. And you have a phenomenal advantage in terms of getting the amount of tumor. You can literally pour the chemotherapy on residual cancer cells rather than diluting it through the entire blood volume by giving it systemically. The selection criteria, what you see here, you want to have a resectable primary, resectable metastasis. We like to avoid extra-abdominal disease, and the patients have to be fit for a big operation. That includes cardiopulmonary, nutritional performance status, and more recently, from some of the other research we've done, a lot of emotional and support for these patients. Patients have to be well prepared for these operations. The better prepared you are when you go in for these procedures, the more likely you are to come out the other side doing well. And these are what we use. We do screening. This year, we're doing routine COVID screening, of course. We screen patients for MRSA, which is a bacteria in resistant staph. We make liberal use of vaccinations for anticipation of splenectomy and a lot of psychosocial support for our patients. How do you do this operation? The operation is done with a goal of complete removal of all the disease. The goal of these cytoreductive surgeries is not to take out the easy stuff, but to get everything cleared out if possible, and then to deliver the chemoperfusion in a uniform fashion. Here we use a 2-hour perfusion. Some centers use 60 to 90 minutes. And again, this is the advantage you get from delivering the chemotherapy into the peritoneum versus intravenously. So that's a peritoneal plasma ratio. You may have heard of the blood-brain barrier. There's also a plasma peritoneal barrier. So delivering the drugs we usually use for appendiceal cancer, mitomycin and oxaliplatinum, is giving somewhere between a 25 and 75 to 1 advantage in terms of delivering drug to target. You may have heard of the PCI, or peritoneal cancer index. This is a measure of how much tumor is in the abdomen. So after we open up or we put a laparoscope in to assess things, we want to see how much is there. We divide the abdomen into 13 zones. Each one is scored 0 to 3. So the scores go between 0 and 39. After we know that, we want to know after we do the operation, we want to know how much is left once we get it done. And this is what they call the completion of cytoreduction score. You might hear a CC score, completion of cytoreduction score. We use an R score, which stands for residual, which comes out of the staging manual for tumors. And basically, you want a CC0 or an R0 or R1, and that just means there's no gross residual left. CC1 is the same as R2A, essentially, and those are CT2 and 3 means there's more residual disease left after maximum effort at site of reduction. And you can use these for prognostication. Again, this is a picture of what one of these perforated tumors looks like. This is our experience at Wake Forest of 949 patients that we've operated on for this as of this week over the course of about 30 years. And this is what shows you what the prognosis looks like. So the top lines are for patients who had complete site reduction on the left. It also shows the lower numbers. You have a curve there, which is low grade versus high grade, with or without nodal metastases. And we can prognosticate pretty crisply in terms of how you're doing. And also know these are not 5-year survival rates, but we're talking about 10-year survival rates and beyond in the 70+% range if a complete site reduction can be achieved. Now, this is a score of what kind of shape is the patient in when they get here to see us. The 0 or 1 means the patient's 0 is in good shape, 1 is minimum symptom. By the time you have significant symptoms, which is called an ECOG-2 status, your prognosis is substantially worse. And for patients who are seriously symptomatic because of the bulky disease, their prognosis is much worse. So we want to get to patients before they're having massive symptoms. The time to come in for this is not when you have trouble eating or with a bowel obstruction. Now, this is a series of the first 1,000 cases we did here at Wake Forest. And what you see here is the 5-year survival rate broken by quintiles or 5 parts. The bottom line is the experience with the first 200 cases we did. And I say that because you want to go to an experienced center, which has a lot of experience with this, because the survival gets better as you go to a more experienced center, significantly better. But what have we learned? These are the key prognostic features for cancer of the appendix. Histologic grade, peritoneal cancer index, how much disease is there, how completely was the resection done, what kind of shape are you in, or the nodes, and again, where is the centers on the learning curves? Now, there's only been really a couple of prospective randomized trials. There was one in the surgery branch of the National Cancer Institute, which was a prospective randomized trial, which wanted to compare cytoreductive surgery with or without HI PEC. And at the National Cancer Institute, where they gave their surgery away for free, they couldn't get the plane off the ground. Unfortunately, they couldn't accrue to this trial, which would have answered an interesting question. There's only been one prospective randomized trial for cancer of the appendix, and I'm proud to say I ran it here at Wake Forest with the assistance of my associates at MD Anderson and the University of Pittsburgh. This is a prospective randomized trial. 133 patients were accrued. And this is a straightforward trial looking at patients with appendiceal cancer with peritoneal dissemination, and we randomized patients to using either mitomycin or oxaliplatin in the perfusate. It took us 6 years to accrue this trial. This was not an easy one to do, and this was not supported by National Cancer Institute funds. This was supported by philanthropy, which is why I'm going to continue to ask everyone on this session to please consider supporting ACPMP and your other regional centers which are doing research for this disease. What did we find for this? There's a difference in terms of what the white counts are, and it turns out that the mitomycin is harder on your white count than the oxaliplatin. The oxaliplatin is a little harder on your platelet count, though not significantly so. But what did we see in terms of overall survival? These are the 2 lines. No difference in overall survival, no difference in progression-free survival in this randomized trial, which is the best data you can get. And again, if you have low-grade tumor, which is the top lines here, you do a whole lot better. Over 90% of the patients are still alive, doing well 5 years later with these low-grade tumors who undergo the HI PEC procedure with a complete site reduction. But whether you had oxaliplatin or mitomycin didn't seem to make a difference. We did find a slight difference. This is an index of quality of life. Over the first 6 months or so, patients had a slightly better quality of life if you used oxaliplatin rather than the mitomycin. So what do we conclude for this? Most importantly, trials for cancer of the appendix are certainly possible. There's some differences in white count and platelet toxicity. Quality of life is slightly better with the oxaliplatin, which is why I use as the default agent here. And they have relatively similar efficacy. We also looked at quality of life, and I'm going to go through this relatively quickly. And I'm going to get to this. These are timelines. On the left is baseline, 1 month, 3 months, 6 months, 12 months. It takes a good month just to have slightly increased pain scores for a month, and then it tends to go down from where it was. So these are big operations to get over. This is my favorite slide in this whole slide deck. And what you're seeing on the left is markers of depression. And a lot of the patients come to us with depressive issues. You'll hear more about this in some of the talks later. And for those depressive symptoms, if you have a HI PEC, by the time you get to 6 months, the risk of major depression is cut by about 50%. That makes going through a high PEC a better antidepressant than Paxil or Zoloft. So we've learned a lot from quality of life. We've learned that sleep disturbances are a problem and we can maintain long-term quality of life. Depression is found in a lot of patients and we screen for that routinely. We also looked at the quality of life for the caregivers of patients. This is a patient study we published last year. We'll hear from Dr. Duckworth later in the morning, who's my co-author on this. We found a number of things. Interestingly, if you look at the depressive scores for the caregivers, it's worse than the patients. Patients going through it are a whole lot tougher, and we've also found the financial worries are not quickly resolved. Those go on for some time. We ask a lot of our caregivers, and for the caregivers who are on this session, thank you, and we support you. We salute you for being there for our patients. We do a lot of research here. We're going to ask everyone, you'll hear a lot about research from some of the other centers. We look at high PEC databases. We have a very large tumor data set. You hear more about organoids, for which we received a prestigious R01 grant. You'll hear from Dr. Votanopoulos a little bit later. We're looking at phase 1 agents and genomic studies, quality of life for patients and family members. And before the sun sets, what am I going to leave you with? This is a rare disease. You know that already if you're on this session. It's increasing in incidence. The grade and resection status are the key prognostic indicators. Experience, where you get your treatment done by the surgeon, by the pathologist, by the whole team is important. Morbidity and stoma rates, there's some complications. It takes a while. Long-term survival is clearly possible for a large percentage of our patients. Genomics are improving things, and we are extrapolating chemotherapy from colon cancer is unfounded. Appendiceal cancer is not the same as colon cancer. So on behalf of our HI PEC team, and we are celebrating our 30th anniversary of our HI PEC program here at Wake Forest this year, I'd like to thank everyone for joining us. And I'd also like to thank everyone at ACPMP for giving me the privilege of speaking with you this morning. Thank you.
Thank you so much, Dr. Levine, and thank you all for tuning in today. My name is Lauren Smith, and I will be the one emceeing the Appendix Cancer Survivorship Symposium this afternoon and morning. And I just want to come on and briefly introduce Dr. Levine for those of you who are just now tuning in. Dr. Levine is the Chief of Surgical Oncology at Wake Forest, and Dr. Levine was the one who just presented. And his research efforts span clinical and translational work with active ongoing support of basic science efforts. The Wake Forest Baptist Cancer is recognized as an international leader in cancer research and therapy for peritoneal surface metastases, and we are excited to have them joining us today. And next up, we have Dr. Laura Lambert, and she is the Professor of Surgery and Director of the Peritoneal Malignancy Program at the University of Utah Huntsman Cancer Institute. Dr. Lambert specializes in the care of patients requiring surgical treatment related to peritoneal carcinomatosis and gastrointestinal oncology. Her main clinical focus is the surgical management of peritoneal carcinomatosis and the use of HI PEC. She's published and spoken extensively on HI PEC, as well as the surgeon's role in comprehensive palliative care. I also just want to reiterate that those of you attending today will be able to submit questions in the Q&A feature that is below during the Zoom, and we will answer them and reply to them live during our open forum sessions from 1:30 to 2 and then from 2 to 2:40. So please submit any questions that you have throughout the program today, and we'll answer them live this afternoon. And from there, I will let Dr. Lambert present. Thank you so much.
Great. Thank you, Lauren. Good morning, everybody. And I just want to also thank the ACPMP Research Foundation for inviting the Huntsman Cancer Institute to be a part of this important symposium. Also want to congratulate Dr. Levine and Dr. Votanopoulos and the folks at Wake Forest on receiving such a prestigious grant for appendiceal cancer. And I would echo what Dr. Levine said, that it truly is a result of all the efforts that the ACPMP Research Foundation has done to bring this to the fore. And I know that their results will benefit not only people with appendiceal cancer, but also people with other types of cancer in similar situations. So we really look forward to seeing what they're able to accomplish with that funding and the research that they have going forward. I'm going to share my screen now, and this is my presentation is going to be about what's new in 2021 with regards to appendiceal cancer. And I love to give this presentation and kind of have an opportunity to review the literature and share with all of you what's happening in the literature and research and how things are evolving and developing. And Dr. Levine's talk actually hit on a lot of things that are evolving and pertinent in the literature and in 2021. And I always like to start with showing the number of publications that have been published in appendiceal cancer and PMP over the course of the years. And you can see how steadily the numbers have increased over the past few years. While it looks like we may be a little bit low with regards to publications in appendiceal cancer for 2021 relative to 2020, if you look at the rates for PMP, they've actually been equal for the past 2 years, so 2019, 2020, and currently in 2021. So we are projected to exceed that this year. And if you take the combined for appendiceal cancer and PMP, it looks like we'll be consistent with or slightly ahead of the number of publications for 2020. So again, a lot of interest in this area, despite the fact that, as Dr. Levine mentioned, this is a rare disease. There is a lot of interest. People are trying to gather data so that we can better understand this disease and better optimize treatment for it and plan for the future as we're moving forward. And so some of the highlights that were in the literature in 2021 included increased awareness, optimizing treatment, better defining and redefining the pathology, as Dr. Levine mentioned. The WHO came out with new fascicles around appendiceal cancer, which, as he also mentioned, some pathologists use the WHO, some do not. The nomenclature remains very confusing for pathologists, for surgeons who don't see a lot of this. So I would just echo his recommendation that if you end up with a diagnosis with a tumor of the appendix, if you can, seek at least a second opinion at a high volume center with a surgical oncologist, medical oncologist who are familiar with these tumors, and the pathologists who are familiar with these tumors as well, and have your tumor reviewed by a pathologist in a high volume center. It's very important. It really impacts treatment recommendations, prognosis, and outcome. So please advocate for yourself, advocate for your loved ones, and get the information that you need. Don't worry about offending somebody. This is important, and you just need to get the right information for yourself. We're constantly working on how to improve patient selection, especially for cytoreduction in HIPEC, as Dr. Levine mentioned. It is a major surgery. We want to offer this to people for whom it's going to be beneficial, and we want to avoid doing it on people for whom it's not going to offer any benefit, because it is such a major undertaking. And as he also mentioned, there are new things coming all the time: immunotherapy, systemic therapy, personalized medicine options, looking at the genomics of these tumors. So we're really working on identifying the best treatment option for the individual person based on the information that we can gather from these studies that are coming out. We continue to look to advance surgery and intraperitoneal treatments. As you know, this tumor tends to remain confined to the abdomen, which gives us a unique opportunity to really explore different ways of treating these tumors. We continue to investigate the tumor genetics, like Dr. Levine showed, and just there's ongoing research continually. So it is a very exciting time, and there's a lot happening. The ACPMP Research Foundation mission is really fourfold. Number one is to increase awareness of this disease, and they certainly are doing a great job at that. It's also to provide education to surgeons and pathologists and medical oncologists about, and to patients and their families as well, about how best to treat this, this disease. They are obviously supporting research in a wonderful way and have been the greatest supporters of research in this disease for a long time. And they're about optimizing treatment. And so those are the things that, as I went through the literature for 2021, again, there were over 300 publications already. I really wanted to focus on some of the articles that highlighted the mission of the ACPMP Research Foundation. And with regards to awareness, as Dr. Levine mentioned, while this is a rare disease, the incidence truly is increasing, and that has come up again with a number of publications in 2021, as well as people trying to identify risk factors to increase awareness that a person might have a cancer of the appendix when they go in to have an appendectomy for another reason. Because as he mentioned, it's very rare that we know ahead of time that this person has an appendix tumor until we take out their appendix. So as he said, we call that an incidental finding. We took out the appendix thinking there was appendicitis, and there was this tumor as well. So is there a way for us to predict that better ahead of time and have kind of a heads up that this might be what's going on, so that as one of the questions that came up in the chat, the surgeon will be alerted to look around more if there's a higher concern or likelihood of a tumor being there. This study from Cancer in 2020 was one that I presented last year that showed the increasing incidence of appendiceal cancer in the US and Canada. These were huge databases that the authors looked at and showed that across all age groups in both the US and Canada, there was an increase in the presence of adenocarcinomas of the appendix significantly, depending on which age group you were in, from 44 or 45% up to as high as 451% increase in the incidence. And this trend has continued. So there are a couple of publications this year by Shannon et al. At the University of Pennsylvania. They went back and looked through, again, another large database, the NCDB, over a 10-year period from 2006 to 2015. They found that there were 8,778 appendiceal cancers identified. 4,233 of them were stage 1 to 3, which was 64%, which meant that 36% of people had a stage 4 tumor, meaning that it had already spread outside of the appendix, most likely in the abdomen. These tumors rarely go to other places, fortunately, but they can. So this was most likely people who had cancer that had spread in the appendix. And what they found was that there was a much higher incidence in the second half of the time period that they studied. So from 2011 to 2015, 68% of the tumors that they identified were in that time period. And they found that the people that were most likely to have them were over 40 years old. And if you were over 60 years old, you were more likely to have what we call a T4 tumor, which means that the tumor has actually broken through the wall of the appendix. And now you're at higher risk of developing a recurrence in the abdominal cavity. And that more patients were in that time period were likely to have had HI PEC at some point. And so I think these are important points. It looks like we're increasing awareness about the role of HI PEC, so more people were having it. We're also becoming aware that people who develop what looks like acute appendicitis in older age, older meaning older than 40, are, the general surgeons need to be aware and the pathologists need to be aware that this is somebody who is at a higher risk of potentially having a tumor associated with the appendicitis. Similarly, this is not confined to the United States, so I do think this is a global problem. They've seen the same thing in Australia, where they noticed a 415% increase over a much longer period of time, over 30 years. And some of the reasons why the authors postulated about what might be driving that are the increased use of CT scans. So we're seeing more abnormal appendixes before people present with symptoms either related to the appendix or that the appendix there's a cancer in the appendix and it has spread. The growing aging population, which we're also seeing here in the United States, And they also hinted at improvements in pathologic assessment of the appendix, which Dr. Levine referred to too. And there was a publication that came out from a group down at Mount Sinai in Miami Beach. This was from the pathologist down there. And I would encourage the ACPMP group to maybe consider putting this on their website if they haven't already done so, looking at the rising incidence and asking the question, does the pathologic handling of the specimen actually play a role in what we're seeing in terms of the rising incidence? So they looked back from 2010 to 2020 at all the appendectomy specimens from their institution. It was almost 1,600. And they found a strikingly high percentage that had tumors in them, so 6.5%. And they similarly found that this incidence increased, so that in 2010, the incidence was 5.6%, but in 2020, the incidence was almost double that, or it was double that, 12.7%. They found that there was a 2.8% incidence in just acute appendicitis, so somebody who was brought to the operating room for the presumption of appendicitis, almost 3% incidence, which is still higher than what I think most people expect. And obviously it was higher if the person was being taken to the operating room to have their appendix removed because it looked abnormal and there was a suspicious lesion. But at the same time, at that institution, they changed their pathologic assessment of how they looked at the appendix under the microscope. And so we'll show you that in a minute, but what they postulated too was, the other questions they asked were, are we seeing more tumors of the appendix just because we're doing more appendectomies? And actually what they found was that's not the case. The rate of appendectomies, if anything, has not increased over the last decade, but actually decreased significantly last year due to the COVID pandemic. But there's been a real push in amongst the general surgery community to consider not doing appendectomies for appendicitis, but for treating them with antibiotics. And if the appendicitis resolves, you can avoid a surgery. Obviously, there's a concern there because you may be missing a tumor of the appendix if that's related. And so that's important. It's important that general surgeons are aware of this higher incident in people who, especially in people who are older, who present with appendicitis, where you may think about treating it with antibiotics, but now maybe you should really be thinking about taking that appendix out to make sure there isn't a tumor. And so then again, here's the rising incidence that I mentioned earlier. And what was also interesting, and Dr. Levine talked about this as well, is that we used to think that it was carcinoid tumors that were the most common tumors of the appendix. But in fact, this study also showed, at least in this patient population, that it was the non-carcinoid epithelial or the adenocarcinomas, the mucinous tumors, that are higher in prevalence than the carcinoid tumors. So in this study, 56% of people had non-carcinoid epithelial tumors, or the adenocarcinomas, or the lamins, those other tumors that Dr. Levine was talking about, and only 23% actually had the carcinoid. So there's definitely, that is also something that pathologists and general surgeons need to be aware of when they're taking care of people that come in with a problem of the appendix. And this is what this group has done. They've done what we call serial sectioning of the appendix. A lot of places will just take the appendix and they'll just cut it in half at one spot and kind of look and see there's appendicitis. And if there was a tumor down at the tip that wasn't obvious either to the eye from the outside or feeling it, they may not actually see that if it's very small. And so this group has undertaken a process of slicing the appendix up in 5 different slices. So they're really looking through the whole appendix. And this can also be important because, as we'll see in another study that I'm going to talk about, oftentimes these tumors can perforate, and we think they have the ability to reseal themselves. And so it may look like the appendix there's no perforation, but somehow cells have gotten outside of the appendix. So clearly there was either a perforation or the tumor has grown through the wall. And unless a pathologist is really reviewing the entire specimen, they may miss that site and understage the tumor in the appendix. So I think this is a really important educational point and an awareness point for pathologists and surgeons. With regards to the risk factors, there were a couple of publications that came out looking through large databases to try to determine risk factors for appendiceal cancer. The first study, which was done by Stopansky et al. From the University of California at Irvine, looked at a large quality improvement database called the NSQIP database that is sponsored by the American College of Surgeons. And they looked at all the appendectomies that were performed over a 2-year period. There were over 21,000. They only found a 1% incidence of cancer in those specimens. But they did note that, again, the rising age put people at an increased risk for a higher incidence of an appendiceal cancer. They also noted that if the person did not have an elevated white blood cell count, which is often a sign of infection, which goes along with more garden variety appendicitis, that there was a higher likelihood of having a tumor present that was causing the symptoms. And if it took the surgeon more than an hour to take out the appendix, then that might be a sign that there was something going on more than just, again, garden variety appendicitis. And so these are things, again, for general surgeons and pathologists to be aware of as they're operating on people for a problem with the appendix or looking at the appendix under the microscope. And then similarly, Skandalis et al. From a number of different medical centers in New York City looked at the NSQIP database over a 9-year period, as well as the experience at 2 hospitals located in the Bronx. And they found a slightly higher incidence of appendiceal tumors in their hospitals, 1.7%, and a lower incidence in the NSQIP database over that longer period of time, 0.5%, which is what Dr. Levine quoted. And they also found that there was a higher incidence with age. So again, the age thing keeps coming up. And what they found in their study was kind of interesting, that if you looked across, this was from the 2 hospitals in the Bronx that they looked at, that the incidence of the epithelial tumors, the non-carcinoid tumors, like we talked about, definitely goes up with the higher age group. So 40 and above, you're starting to see fewer of the carcinoid tumors and more of the low-grade mucinous neoplasms and just the frank adenocarcinomas, the real cancers of the appendix. And even in the 90th decile, the 80 to 89 age group. So if somebody presents with appendicitis in their 80s, you really have to have your antenna up that there could be a cancer. And this is not somebody you just want to treat with antibiotics. You need to take out their appendix if they're fit enough to have that done. And then also this year, Peltrini et al. From Naples, Italy, from the Department of Health there, put together a meta-analysis. So they looked through all the literature that published on what we call complex appendicitis, where there is an abscess or a lot of inflammation around the appendix, where the surgeon might be leery about taking the person to the operating room right away and want to treat the person with antibiotics up front, and then take the person later for what we call an interval appendectomy. So that's usually about 6 to 8 weeks later, after the inflammation and infection have settled down, to make the surgery easier and safer for the person. And what they found was that with people who had presented with complex appendicitis, that there was an 11% incidence of a tumor being involved in that. And other studies have shown that as well. This is a slide that I presented last year reviewing this literature, a number of studies that showed as high as 30% incidence of a tumor in somebody who presents with complex appendicitis who goes on to have that interval appendectomy at a later date after being treated with antibiotics. And so again, this is definitely a patient, a group, a population where people really need to have their antenna up that there could be a tumor, that the appendix should come out as soon as it's safe to do so. And again, back to the, one of the other core missions of the ACPMP Research Foundation about education. And really the goal for that is to optimize management. And there were a couple of important studies, I think, that came out this year that are really helping us try to educate people to optimize management. And this was a study by Hayes et al. From the Swedish Medical Center up in Seattle, where again, questioning that need, is interval appendectomy really needed? So for people who have that complex appendicitis, do we need to go back and take out the appendix? And the answer is yes. So this was over a 10-year period They looked at 402 patients who had complex appendicitis and in that interval appendectomy. They found almost a 10% incidence of neoplasm. And again, you can see here that rising incidence with age, 43% in people who are over 80 years old. And also they noted that if the surgeon had to, so most people, when surgeons go to take out the appendix, we routinely start laparoscopically, if at all possible, meaning using small incisions in a camera and small instruments. And for the vast majority of the time, we can get the appendix out that way safely. But if a surgeon has to convert to open, meaning they have to make an incision because the surgery is it's not safe to proceed laparoscopically, it's very difficult. That's another indication that there might be a tumor present that's making the surgery more difficult. And the surgeon needs to be aware. If that's the case, they really need to take a good look around the abdomen. The pathologist needs to be looking very carefully at that appendix. This is a study that came out of the group it's actually a multi-institutional study. 7 institutions participated. The lead authors were from the University of California at San Diego. And they wanted to determine who's at risk for recurrence if they've had a tumor that's removed, what they call localized tumor of the appendix. And they looked at localized, specifically lamin, so the low-grade mucinous neoplasms, over a long period, almost 30 or over 30 years. And they identified 217 people who had localized lamin, meaning that there was no obvious evidence that it had perforated and spread through the abdominal cavity at the time of surgery. Median age was almost 60. 60% of the patients were female. They had a good long follow-up, 51 months. And what they found was that there was actually a very low incidence of recurrence. This is the good news. Only 7 patients recurred. They did so within, on an average, about 14 months, although the span ranged from 2.5 to 47 months. And there were 7 patients who had a positive margin, meaning that when the surgeon took out the appendix, we often use staplers, and we sent the appendix was sent to the pathologist. When the pathologist looked at that margin where the appendix was divided to separate it from the colon, there were some mucinous cells, tumor cells at that margin. Oftentimes there will be a recommendation to go back and resect that margin to make sure it's clear. But what this group showed that even in the setting of positive margins, there were 0 recurrences related to this tumor. This data is supported by other studies in the literature from earlier time that have showed a similar finding. And so personally, in my practice, I've no longer recommended going back to resect a positive margin for this type of tumor. So again, something, to be referred to a high volume center for somebody who sees this all the time and knows this literature to get the optimizing the best recommendations for you. This is the flow sheet of this study. Here's the 217 patients in the middle. And then they looked at how they were treated. So 124 just had appendectomy, 26 had appendectomy and a resection of the base of the cecum, or the part of the colon where the appendix comes off, and 67 actually went on to have, formal resection of their colon, really auspiciously to test the lymph nodes in that area. But what we know about these tumors, and the authors make this very clear, is that they have no capacity to spread to lymph nodes. And so spreading into lymph nodes, doing a colectomy to test lymph nodes for this type of tumor really shouldn't be recommended. If it requires a colectomy to remove the appendix, then that is a different situation. And so the authors show here the rate of recurrence with the different approaches, and showed that doing a colectomy did not improve the risk of recurrence. Once the tumor cells have spread outside of the appendix, taking out the colon doesn't prevent a recurrence in the abdominal cavity. What they did find was that all of the recurrences were associated with perforation. And they also looked at the presence of the mucin, whether it had cells or not in it. And they found that, that there were patients who had recurrences without cells, some with cells, and some with no mucin and no cells outside the appendix. So again, this comes back to that idea of if there are cells and there are mucin outside of the appendix, there has to have been some sort of breach of the appendiceal wall, whether it was a frank perforation or just some migration, pushing of the mucin through the appendiceal wall. Because you can see over here, in these groups where there was no perforation or no known perforation, there were patients who had cells outside the appendiceal wall. And so again, coming back to that very thorough investigation by the pathologist who can pick up a perforation that is not necessarily seen by the surgeon. Here's another very important topic that I know the ACPMP Research Foundation has been interested in pursuing and optimizing, and that's for female patients who are misdiagnosed with an ovarian tumor up front and then undergo large pelvic operations only to then find that they had an appendiceal tumor and should have really been recommended to have a different approach to their treatment. And this was a group, again, also down in, 3 institutions across the country who looked at the number of, over a decade, identified patients who had cytoreductive surgery and HIPEC for appendiceal neoplasms, and then went back to see if they had who had prior pelvic operations for GYN malignancy. And out of 36 patients, they found that 18 of them, or 50%, had actually had a previous operation for presumed GYN malignancy. And what they found was that when these patients got to cytoreduction and HIPEC, they actually had a higher PCI. So Dr. Levine reviewed the PCI, that grading of how much tumor there is, 21 versus 9, and the highest score is 39. They had a higher blood loss at the time of surgery, 650 mLs to 100 mLs. They had a longer length of stay in the hospital, 12 versus 8 days, and a higher rate of complications. So really, really important, ideally, to make the proper diagnosis before somebody has a major surgery, like the women have for ovarian cancer. And the next aspect is, the clinical. This is really the frontier. I am just going to highlight one study by Berger et al. This is from the University of Chicago, and Dr. Turaga, who will be speaking to you, is one of the authors on this study as well. And this is, I think, really kind of the frontier of where we're going clinically, not only in appendiceal cancer, but other peritoneal surface malignancies, looking at the role of intraperitoneal chemotherapy with or without heat. And this was a study that they published this year looking at the use of what they call iterative HIPEC, meaning multiple HIPECs without cytoreduction for patients who had high-grade adenocarcinoid cancers or goblet cell cancers of the appendix that could not be removed surgically. And they identified 7 patients for whom they performed this treatment. And what they found was that the average survival for these patients who had the iterative HIPEC was almost 25 months compared to 8 months with systemic chemotherapy alone, and 16.5 months with patients who had cytoreduction and HIPEC. And here's some illustrative pictures. I hope this projects well, where you're looking to see the response in the peritoneum before HIPEC and before the 3rd HIPEC. So these patients would have up to 3 HIPECs. And you can see all these white spots on the left diaphragm here, how they're sort of fading away over here, as well as this white plaque-like lesion here down in the pelvis. And you can see that it's fading away here. And I think this is the most dramatic image here. This whitish plaque-like looking area is tumor on the right flank or the right side of the abdomen. And here you see, this is what normal peritoneum looks like. So you can see that these iterative HIPECs were having a direct impact on these tumor implants. So more to come. This is, again, I want to reiterate, this is a very highly selected group of patients at a very high volume specialized treatment center. So, but more to come on this. This is the frontier. This is where things are heading. And the research is really the future. And I know we're going to have a talk on the Bronack trial and the status of that, but I wanted to just highlight this one study from the University of Pittsburgh, who is taking this Bronack approach one step further and looking at whether the bromelain and the N-acetylcysteine that can break down that mucin that these tumor cells make and help expose the cancer cells that are there, the cellular part of it, to chemotherapy and make them more sensitive. And that's what they were able to do in both what we call ex vivo, meaning in tissue culture, and in vivo models. So in animal models, they treated mucinous and non-mucinous tumors with the bromelain and the N-acetylcysteine or Bronac with or without chemotherapy. And they found that the mucinous tumors were more resistant to the chemotherapy because they were protected by that mucin and the chemotherapy couldn't get there. But after they treated with the Bronac, the cells became more sensitive to the chemotherapy. They were able to remove more fluid because they've liquefied that mucin so you can extract it. And they found that the tumor burden was less. And here's a couple of, this is just a figure from their study showing that when they added the Bronac to mitomycin C, they had a higher rate of cell death. And here's some actual pictures from that study that showed this is what the mucin looks like. Again, kind of that apple jelly consistency. And then when you treat it with the bromelain alone, it really doesn't have as much of an effect. When you treat it with N-acetylcysteine, it doesn't have much effect. But when you treat it with the combination, you get this really liquefying effect that can then be extracted. And they also saw this in the animal model. So here's a control rat actually with a high volume of that pseudomyxoma and mucinous tumor. This was an animal that was treated with the Bronac, and you can see here that volume of tumor is much lower. They were able to extract more fluid. It was more liquid. And here's when they surgically removed the tumor, you can see the decrease in the volume. And I know Dr. Levine is going to be talking to us about this study and its status in the United States in a future session. And so I just wanted to, there was another question that had come up in the Q&A that there are now 7 clinical trials that are appendiceal specific that are open and recruiting in the United States. You can find those on clinicaltrials.gov, and also the ACPMP Research Foundation keeps an updated list of those trials. And again, the literature is just showing that the data is continuing to reflect what we're seeing in terms of the incidence of appendiceal cancer. And we just need to keep working with the ACPMP Research Foundation to increase awareness about appendiceal cancer so that we can optimize management. And I can't stress, like Dr. Levine did, the need for early referral to a high volume center of excellence for this disease. And that the next generation of treatments is really starting to unfold. We're constantly being asked, is there anything new? Is there anything new? Slowly it's coming, and things are evolving still. And the research continues, and the research is going to inform us and keep pushing that frontier of clinical options that we have. And so I just want to leave everybody with the message that there is hope. Things are moving forward with the support of the ACPMP Research Foundation, with this new funding from the NCI, which is fantastic. And I just again want to thank everybody for the opportunity to speak today and look forward to the roundtable.
Thank you so much, Dr. Lambert. It was great to have you present today, and we look forward to having you join us for the roundtable Q&A. Up next, we have Dr. Turaga with the University of Chicago. Dr. Turaga is an associate professor of surgery and the director of the Regional Therapeutics program at University of Chicago Medicine. He has a special interest in the treatment of advanced malignancies, including metastatic cancers, and he is an expert in regional perfusion, including HI PEC. He is highly skilled in minimally invasive approaches, including robotic surgery, and uses these innovative techniques to surgically treat and remove life-threatening cancers with smaller incisions and shorter recovery times. Dr. Turaga is an avid, influential researcher and has published over 100 peer-reviewed articles. So please welcome him, and you're up next, Dr. Turaga. Thanks.
Thank you, Lauren, for that wonderful introduction. I did want to say that, while I have done a lot of robotic surgery in the last few years, it's been more laparoscopic than robotic, so I did want to amend that. But I welcome all of you to our conference today. I hope you get a good flavor of what is going on in the field of appendix cancer. I think it's very important that in rare diseases such as appendix cancer, that patients, physicians, researchers, caregivers, we all come together to advance the field. Because I think unlike other cancers like breast cancer or lung cancer, prostate cancer, which are also bad diseases, there is a lot of awareness, there is a lot of research, there's a lot of dollars to support people who are trying to advance the field. But in our field, I think it is very important that we all come together to fight this disease together. And to that end, I would say that, the efforts from ACPMP and certainly from all of our patients in supporting research that has been going on over the last decades, as you heard from Dr. Levine's group, Dr. Lambert, and then certainly many other of our colleagues who are not here, it is critical that we try to improve this field. So my talk is not, it's meant to make you all think a little bit. This is not something that I would say is prime time and is ready, but I do want all of us to have our fingers on the pulse here, just to have a sense of what is going on and what are things that we all need to be aware of and advocate for our loved ones, or if you have the disease yourself, for yourself. So I have no disclosures, and so I'm going to just talk about some selected research concepts. This is not meant to be comprehensive in any way, but this is meant to just stimulate all of us to think about it, and perhaps maybe taking up on Dr. Lambert's point earlier, maybe just help think a little bit about clinical trials and how do we look at that. So I'm going to talk about 4 big concepts. And these are concepts that, oftentimes patients hear about or ask us questions about. I think as researchers, we're very excited about. And I'm hoping today in the symposium, you will get some flavor of this from the different speakers. And so I don't want to steal any of the speakers' thunder, but I just wanted to lay out the alphabet soup and sort of what we're dealing with and what's coming up later today in the symposium. So the microbiome is an incredibly important part of the human body. And we have for long known that, bacteria constitute a large percentage of our body. In fact, a large percentage of stool is made up of bacteria, a large percentage of our body is made up of bacteria, such that in fact, there's more bacteria in our body than our own normal cells. And so it is not that difficult to believe that the composition of bacteria or the type of bacteria that we have in our intestines, in our tissues, could somehow influence disease. And there's always this problem of, is it a bystander? Is it causal? Which means, are the bacteria actually causing these problems? Or are they just kind of hanging out and we're just seeing it more often? And so there are now several studies, and I would focus your attention a little bit on colon cancer. You heard Dr. Levine mention how colon cancer is distinct from appendix cancer. The amount of research on bacteria for the appendix is somewhat limited. There are some groups that have looked at it, including Dr. Sardi's group at Baltimore. But I will still say that this has some relevance for us as we think about research moving forwards for patients with appendix cancer. There are bacteria that have been found, such as Fusobacterium, which are associated with an increased incidence of GI cancers, so all cancers of the intestinal tract. And so it is very interesting to see that there are bacteria that are enhancing the development of cancers, and then there's bacteria that are reducing the effect of cancer. And if you think about bacteria, there's 4 clusters of how I would suggest we think about the bacteria. And those which can be used as treatments, that actually you can give these bacteria and see if actually patients do better. You can see bacteria that are associated with as biomarkers, which mean that they allow us to think if this would potentially make it easier for us to have therapies. It allows for potential for prevention, such as Bifidobacterium, found a lot in yogurts and cultures like that. And there's a lot of companies that have Bifidobacterium capsules as probiotics for patients to take to see if we can prevent cancers. And then certainly tumors that are associated with carcinogenic risk, so which actually cause cancer. And then can you actually use those as markers to identify that? And Fusobacterium is one of those as well. There's some very interesting evidence that that some of these, and again, these are all animal experiments, so it is something that is not, say, ready for human prime time. But one of our collaborators, one of our colleagues over here at the University of Chicago, has done some experiments where they took patients or they took mice and they cut their colons and they put a type of bacteria in it called E. faecalis. And with the E. faecalis, what we could see is that if you look at this graph on the right-hand side over here, I'll just kind of annotate it so you can see. So this graph is basically looking at mice that ended up getting either just fatty food or what they call equivalent of a high fiber diet called chow. And so you can see that when the mice just had chow, the amount of cancer was very little. When mice had fatty food, they had more cancer. And when mice had fatty food with a type of bacteria called E. faecalis, the amount of cancer that occurred after these cancers were cut out was incredibly high. And so this is brought up questions of how should we think about cancer in mice? And then will this somehow affect human beings? Is this something that we need to think about for human beings? And so, the biggest question everyone asks is, how do we interpret this data? Should we be, taking probiotics? Should we start altering our diet so that we're eating more bacteria in some form? And the answer is we don't know the true answer in this space. We do know that there is no question that this will become a very important part of the management of cancers in the next few years. And so I strongly would encourage all of you to certainly keep an eye on it, watch out through venues like ACPMP for any ongoing research. There are trials with antibiotics that's going on at the Mercy Medical Center. I do think in the meanwhile, the easiest recommendation is to eat food with healthy vegetables and fruits, if that's okay with your clinical team. So just getting back on the concept of diet, though, the question is, can we alter in some way the diet, and how does diet make a difference? It's a very common question we get, that patients ask us, are these tumors fed by sugars? Should I stop eating sugar? And the premise for a lot of this came around when people saw PET scans and you were giving sugar to see if the cancer cells were taking up sugar. And so this whole myth came around of the fact of, are cancer cells eating up sugar? And so should I stop taking sugar? The bottom line answer, as far as we know, is that, cancer cells, just like other cells, take up energy. They're just dividing faster, so they take more energy. And so therefore, they are fed. But if you starve yourself, it's likely that you would starve even your normal body. But there is some interesting science that is coming up in the concept of the fact that cancer cells eat sugars or metabolize sugars very differently than normal cells of our body. So this is one of the papers that came out from a big group. And again, this is just sort of showing cells that are cancer cells that as they kind of travel and they kind of grow, the type of stuff that they use, the glucose that they use, the sugars that they use actually change. And the way that they use it can be with different types of phosphorylation, which means if you think about it, when you run and you get cramps, it's sort of the buildup of lactic acid. A lot of these tumors are now relying on some version of anaerobic metabolism, which means that these cells are growing so fast, they're not able to keep up with the blood vessels bringing glucose to them. So they start burning other substrates or burn it in different ways without enough oxygen. And so that is a very, very important concept, because can you actually alter that? And does it have any significance for peritoneal metastases or cancers that spread along the lining of the belly? And this has been looked at by several groups, including one of our colleagues over here. And this basically has found that these are sort of mice experiments. Again, you can see sort of the intestines over here. And they found that the adipocytes, so the fat cells within the fat curtain of the body called the omentum, are really the energy houses for these cancer cells that are in there. And if they have more of these adipocytes expressing some of these genes, you can actually cause these cancers to grow more. And when you block the fatty cells from stimulating this, the amount of cancer growth is lower. So a very, very interesting space right now of thinking of what we call metabolomics. It is something that we have been looking at as well. And one of our patients was one of the first to actually participate in a trial for looking at how appendix cancers eat and metabolize sugars. But what is clinically relevant for all of us? How should you take this message? The message is that people have studied what happens to folks that are eating very high fatty diets before they go for big cancer surgeries. And they found that the liver accumulates a lot of glycogen, and actually patients do worse. They bleed more from surgery, they have more problems. And so it is certainly something that if you are obviously in consultation with your clinical team, if you are in a position to alter your diet such that you're able to eat more healthy and less fried foods and fatty foods, it may make it safer for your surgery, certainly with less blood loss. And this is a clinical trial that was done. So again, not a mind-breaking, groundbreaking message, but clearly eating healthy makes a difference. We do think that the way these tumors metabolize energy will come into play very soon in terms of how we are able to intervene and how we're able to prevent these cancers from growing, occurring, and certainly causing morbidity for our patients. The third thing that I just wanted to discuss a little bit is precision medicine. You've heard these terms a lot. This is an incredibly complex field. Later today, you're going to hear talks that will discuss sort of precision markers. You've heard a little bit about gene mutations. You've heard a little bit about these concepts, and it is very important to understand this as best as you can. And certainly there's resources online, including from the White House's Precision Medicine Initiative. But precision medicine means really, can you actually target the cancer, and can you tailor the treatment for the patient? So really, how do you make the treatment as personalized as it can be for anyone who is undergoing treatment? And so if you think about the types of treatments, anti-cancer treatments we have chemotherapy, which is very broadly, it hits everything. Anything that's growing or dividing, it goes and kills it. So you lose hair, you lose taste, you feel not so well. And that's because it's just a generic, it's sort of like a blanket, it's like a carpet bomb. You just throw it on everything. And then you have hormone therapy, which is more specific to cells that only have hormone receptors. We don't use that in appendix cancer. Then there's these epigenetic modifiers, which basically change the way cells replicate. So they kind of work on these support structures in the DNA that helps prevent them from replicating. Again, not something we use often in appendix cancer. Immune stimulators and checkpoint inhibitors, so immunotherapy, that I'm sure a lot of you have questions about. There's 2 sessions dedicated to discussing immunotherapy, but something that we are excited about seeing how we can activate in patients with appendix cancer. Angiogenesis inhibitors, so targeted agents that actually reduce delivery or traffic of blood vessels and blood supply to cancers. Much more specific, much more precise. Bevacizumab, or Avastin as some folks call it, is something that many patients or family members might be aware of. Certainly vaccines and adoptive immunotherapy, which is where you take cells and actually bring it in. I'll talk about that briefly later. And then antibodies, which are specific to your cancer. And then finally, drugs which are so targeted, so precise to your cancer type that allows us to take care of this. But there are 2 types of gene testing, and it's important to understand both. The first is called germline testing. Germline testing means I have cancer. Am I going to transmit it to my kids? Or my parents had cancer, will it come to me? We have never truly established any germline mutations for appendix cancer or appendix disease. However, it is interesting that now, even in previously seen cancers, which we thought had no family histories, like pancreatic cancer, now we are finding germline mutations which don't correlate with the family history necessarily. It may be something to be aware of, and certainly, you have to discuss with your clinical team whether it's a worthwhile thing to get germline tested, which means to test and see if this is transmitted in families. We have no evidence to say that it is important in appendix cancer right now. But the more common testing that happens to a lot of our patients is somatic mutation testing, which means we take the cancer and then we break it down, look at the DNA, and try to study it under the microscope to see what it is. That's where you see these reports which say you have KRAS mutant, P53 mutation, CHEK2 inhibition, CHEK2 mutations. So whatever these mutations you will see are part of the somatic mutation. This language has to become part of your dictionary. You do need to know what this is. Why? Because as you'll hear from Dr. Votanopoulos later and others, this is where excitement in precision medicine is happening. Can we take your tumors, study the mutations, develop a model where we can understand what these tumors grow like, figure out what treatments work for it, and then treat it? And how can you grow it? You can grow it in something called organoids, which are balls of tumor. You can grow it on cells, which are sort of layers of tumor. You can grow it inside animals like mice. You can put it in mice and pigs and gorillas and see how these tumors grow, and then kind of treat it and see if it works, and then take the same treatment and give it to patients. There's platforms which don't rely on any of this. But the problem with this technique right now is we know these tumors are very heterogeneous, which means that if I take a tumor from one part of your peritoneum and another part of your peritoneum and the appendix, they would all be slightly different. And we also know that there's pressure. As we give more treatments to these, we do a HI PEC, we do another surgery, these tumors evolve. So what looks like one mutation at one time point may be different at a separate time point, may be separate in a different location. And so it's very hard to be precise to treat one tumor when this thing is evolving and changing. And so this is another concept you're going to hear later today. And so stay tuned. These are very exciting talks, but can we use liquid biopsies? Can we find cancer cells in the blood and use these as tests to identify which cancers need to be treated, which cancers can be treated better? So if you have appendix cancer that has been completely removed, but then it's coming back and it's growing, and we've tried chemo A, like FOLFOX or FOLFIRI, and it's not working, can you actually study it, be precise about what you're going to use to treat it, and then monitor the response using cell-free DNA? So very, very exciting concepts being developed, I think also being developed very strongly in appendix cancer, thanks to a lot of research funding from ACPMP. So I do think that this is exciting in terms of where this field is headed. This slide basically kind of shows how we think about immunotherapy. There's sort of broad 4 or 5 classes of immunotherapy. If you look at the columns, they're sort of that. The first is using viruses to kill cancers. There is a clinical trial looking at using viruses implanted directly into the peritoneum for patients with appendix cancer to see if you can actually kill cells and then release these sort of proteins that then your body can identify, kill, and see if it can improve the response. Certainly, can we uncloak cancer cells? Cancer cells kind of mask themselves with like an invisibility cloak, like from Harry Potter. And can you actually take this cloak off with what we call PD-L1 or CTLA-4 and make our normal cells fight them? And then the more exciting part is, can we actually take cells from the outside or take your own cells, grow them, and then put them back in your body and activate them, make them sort of modify them such that they can actually find your cancer and kill them? And these are very exciting spheres of immunotherapy that you're going to hear about later today. But it is important to remember that the body's metabolism, so your own body system, the fats you eat, the behaviors you have, do interact significantly with immunotherapy, the bacteria that are in there. So it is important for us as researchers to understand the whole spectrum of seeing what the patient is bringing to the table, what the treatment brings to the table, and how do you marry both of them together. But it's a very exciting time for research. And this is a technology that I think will probably win the Nobel Prize very soon, but it's the CRISPR technology, where you can do gene editing, you can modify genes, and now there's CRISPR technology for T cells. So can you actually take your fighter cells, the immune cells that are fighter cells, and then edit them, and then say, okay, this is targeted to appendix cancer for Mr. A, and it goes directly to the appendix cancer for that patient. So this is very exciting technology, not prime time yet, but keep your ear to the ground so you can actually hear about these updates that are coming up, and certainly support research if you can. But what should everyone know? Everyone should know your genetic test results. If anyone has had somatic mutation testing or germline testing, you need to know what it is. You need to have the report with you. You need to carry it with you when you go see your oncologist or your surgical oncologist to discuss this. You need to be able to discuss intelligently at some point the role for personalized testing, and you're going to hear more about it later today, the role of cell-free DNA testing, and it is something that will become prime time in the next few years. And I do think it's important to stay connected with platforms such as ACPMP. And finally, in the last couple of minutes, I just wanted to share a little bit about trials. You heard this already, but clinicaltrials.gov is probably the most comprehensive resource for finding clinical trials. You can use filters. So you can see over here, we have some filters that I put in over here: appendix cancer, neoplasm, tumor, and you'll certainly see trials that are there. You can see in this search, there's about 18 studies that you see, but not all of them are therapeutic trials. Not all of them are relevant to you or your family member. So be careful in what you find. Make sure you discuss this with your clinical team. But what is more exciting is that now we're thinking about tumors more based on their mutational profiles. So yes, it's important that the cancer comes from the appendix, but now maybe you can treat an appendix cancer the same way as you would treat a lung cancer or prostate cancer if it has the same mutation as the lung cancer and the prostate cancer. So this is an interesting new development where we are starting to think about cancers more than just where they're coming from, but we're thinking about them more as where they're coming from, along with what they contain and what mutations they have. So it is important to look for targeted trials. This graph on the top shows that when patients are treated with personalized treatments, looking at their mutational profiles, they tend to do a lot better. So this is the survival curves of different types over here. And this is a big meta-analysis looking at lots of studies and finding that whenever patients are offered personalized treatments, they tend to do slightly better. It doesn't mean there's always personalized treatment available, but certainly something to be aware of and looking at. So finally, I would just say, there is a lot of information out there. There is a lot of misinformation also out there. You have to use your clinical team as a guide. They will help you navigate treatments. We're all in this together to try to cure cancer. And I think the best thing we can all do for each other is to advocate for better research and to make sure we support organizations such as the ACPMP to help reach this mission. So thank you again.
Thank you, Dr. Turaga, and thank you everyone for tuning in today. We're running a little bit behind schedule this afternoon, so I am gonna quickly go through my presentation, which is on the overview of the ACPMP Research Foundation, as well as an overview about the Patient Advisory Council, which is a new initiative that started in 2021. My name, again, as I said, is Lauren Smith. I'm your MC for the event today, and I am the next presenter. I'm going to share my presentation here. 1 second. Sorry. Thank you so much. So I began this role as one of ACPMP's first staff members after my diagnosis at the age of 21 with an appendix tumor. And I am, like I said, the development and communications manager. And I wanted to turn my diagnosis into an opportunity to be an advocate for this rare disease. So you may have been hearing ACPMP Research Foundation throughout this presentation this morning, and we wanted to give you a background about who we are as an organization. So we are a 501c3 nonprofit that was created in 2008 by a community of individuals affected by appendix cancer and PMP. And our mission is twofold. We are dedicated to funding and supporting research to find a cure for PMP and appendix cancer, as well as funding and supporting educational and awareness programs, scholarships, and resources to better educate physicians, the greater medical community, and patients about these diseases. Most of you may have seen these slides before, so I'm gonna go through them pretty quickly. This is our board of directors. These are our staff members. And this is our medical advisory board. So ACPMP's research approach is essentially seeking out objectively worthwhile research, and we use a rigorous RFP submission process. We focus on basic science and foundational medical research that can be used to better support more robust studies, including genetic profiling and immunotherapy. Since 2009, ACPMP has awarded $1.3 million in the form of 27 research grants worldwide. We host different patient and physician educational symposiums, including the one today that you guys are participating on. On the right-hand side is a list of some of the different symposiums that we have helped host. We sponsor physician scholarships for physicians and medical professionals to attend different educational conferences. Again, on the right-hand side is a list of different events that we have helped provide scholarships for. And here are some of our patient empowerment patient empowerment initiatives that we support and we provide to our patient and caregiver community. A new patient guide, which is essential for those newly diagnosed or anywhere in their journey, just with a step-by-step kind of guide of where they should find specialists or where they can find online support forums. As Dr. Lambert mentioned, we have a clinical trials page. So it explains and identifies clinical trials that are currently actively recruiting appendix cancer and PMP patients. We have a patient registry that's in the works and going to be coming very, very soon. And basically, it's a collaborative effort with the National Organization for Rare Disorders to better study and educate about appendix cancer and PMP. And as mentioned, we have a Find a Specialist map tool on our website, which is a complete map of the US that lists any specialists that treat appendix cancer and PMP by state. So you can take a look at that. And if you have any questions about specialists outside of the US, you can contact us. We also provide different helpful resources. Here's just listing a few links to online support forums, such as Facebook groups. We have financial and legal links that are listed on our website. We have health insurance information, nutrition resources, and different printable informationals that are all online. So getting into our Patient Advisory Council, as I mentioned, this is an initiative that we started this year in 2021, and it's a patient volunteer group that basically works alongside our nonprofit to better broaden our community of volunteers and contribute to our work in many different ways. It allows for patients, caregivers, and advocates to become more involved with bringing ideas, enthusiasm to help make a difference for our community. Some goals of the Patient Advisory Council include providing perspectives from the patient and caregiver experience, and that can range from newly diagnosed into long-term survivorship. They provide feedback on our programs, services, and our brand identity. Our Patient Advisory Council members participate in quarterly meetings where they receive information and materials related to research and education, which they then disseminate to the community to better provide information, awareness, and different events that ACPMP is hosting. The Patient Advisory Council also hosts different online meetings to connect and provide support with others in their local area, which I will launch into here. Let's see. Sorry. Oh, a little too forward. So those are called the Appendix Cancer Allies. As I said, they're online right now, given the status of COVID, but eventually we'd like to have them safely in person. And it's just an opportunity for fellow appendix cancer and PMP patients and caregivers to connect with each other locally. As we all know, with this rare cancer, often we feel isolated and alone. So it's a great opportunity for patients, caregivers, advocates to connect, provide support, share information, swap questions, and that sort of thing. So we've had great success with them so far, being over Zoom. We've hosted them in Minnesota, Missouri, Wisconsin, and the greater Southeast region so far. But we're hoping to host more in the future. So if you want to learn more about those, you can go to our past events page. If you're interested in learning more about our Patient Advisory Council or you want to join, the application is available in November. We'll be posting about it, but you can also go to the link that's shared below. And if you are volunteering and you are interested, essentially you'll be giving back, you'll be joining a community, making a difference, and staying informed on a cause that you care about. So let's be social. As I said, we're the Appendix Cancer Research Foundation, and we are all over social media. You can sign up for our mailing list to receive emails directly to your inbox. And we are the 501c3 nonprofit today that's co-hosting with the 3 institutions. And we're so excited to have you all join us. So thank you again. And up next, I want to introduce Dr. Shergill. She's with the University of Chicago, and she is a skilled oncologist who specializes in providing comprehensive care to patients with all stages of gastrointestinal and lung cancers, with an expertise in treating colon, rectal, and appendiceal cancers. She's currently developing novel therapies so she can offer her patients innovative clinical trials. And she's an executive officer for experimental therapeutic trials at Alliance for Clinical Trials in Oncology. And so I thank you, Dr. Shergill, for joining us today. I want to let the panelists and attendees know that we are skipping over the 5-minute break today, just to keep things on track. So stay tuned, and we'll have a break coming up soon. Thanks.
Oh, I'm sorry, just having some delay at my end. I am going to share my screen. I apologize, again, having just a little bit of tech issues. Okay, so hello everyone, thank you for bearing with me for that. Hope you're having a good conference so far. It is my honor to speak today at the symposium. My topic is to talk about systemic therapies for the treatment of appendix cancers. These are my disclosures. And the objective of my talk is to go over some of the treatment options and how I make decisions for patients for appendix cancers currently, and then future possibilities. So as has been discussed multiple times in other talks today, appendix cancer is very rare. The incidence is about 6 patients per million population. Often the presentation is that of abdominal pain, and patient gets imaging and then a surgery. And then either in the surgical specimen or at the time of the surgery, the cancer is identified. Prognosis for patients with appendix cancer actually really depends on the type of subcancer they have and the grade of the tumor. Prognosis can range from 10 to 90%. These are the 5 subtypes of appendix cancers. Another talk will go over this in much more detail, but I just wanted to mention them because I take all of this into consideration as I'm making decisions for patients for therapy, especially chemotherapy. There's mucinous appendix cancers, goblet cell cancer, colonic type non-mucinous adenocarcinomas, the signet ring cell adenocarcinomas, and that is the focus of my talk today. There's also the neuroendocrine non-epithelial tumors as a subtype of appendix cancer, which I won't be discussing in this talk. Appendix cancers have a really high propensity to metastasize to the peritoneum. So they're especially amenable to regional therapies like cytoreductive therapies and the HI PEC chemotherapy approach. The penetration of HI PEC, though, is only about 2 to 5 millimeters into the tumor. So HI PEC is not the primary way we give chemotherapy for the treatment of this cancer. And metastases outside of the peritoneal cavity is rare, although it can happen, and we have seen cases like that. What things do I consider as I'm making decisions of how to offer treatment for a patient? We look at patient-related factors like comorbidities. What are some other medical problems they have, the medicines they're on, and how would my treatment implement any changes in those? Symptoms, both from disease and from other conditions, and something called performance status, which is how a patient spends most of their day. Are they up and about, or are they in bed because of their disease or other medical problems, to see how they would benefit. And this has shown if we carefully pick therapies based on these factors, patients do better with those therapies than one therapy for all. So it's not one size fits all. And I also look at tumor-related factors, the type of cancer, plan for surgery, whether the patient is a surgical candidate or not, whether the tumor can be resected completely or not. And then very important is the grade of the cancer, low grade or higher grades like grade 2 or 3. This is showing, this is for mucinous appendix tumors, grade 1. generally tends to have a higher overall survival than grade 2 or grade 3 cancers. But in grade 1 tumors like Lambert, the role of chemotherapy is limited. Generally, it's accepted that chemotherapy is not needed for grade 1 or low grade tumors. In this study, we're showing that it actually did not benefit patients if they received chemotherapy or they did not receive chemotherapy. There are some other predictors of success for those patients, things like comorbidities, as I mentioned, age of the patient. So younger ages tended to do better, females tended to do better, and then use of chemotherapy did not correlate with outcome. However, surgery did. So in lower grade tumors in Lambert, we do not use chemotherapy. However, in higher grade, like grade 2 or 3 tumors, chemotherapy is used. These are data looking at the use of chemotherapy before surgery. So there is a plan for surgery for that patient, but when do we give chemotherapy? Actually, the graph on the left shows that patients, whether they got chemotherapy before their surgery or after, did not make a difference. However, patients who got before and had a response, like a histologic response, did much better as far as overall survival was concerned compared to those who did not have a response. So how do we use these data? We offer chemotherapy to patients upfront, and then we do assessments as time goes on during the course of their treatment to see if they're responding or if they're not responding. We use imaging, we use tumor markers, and we sometimes go take a laparoscopic look to see what kind of response the patients had to make then the decision of when is the appropriate timing for surgery. And then typically we would do chemotherapy after as well, depending on how much chemotherapy a patient received upfront. In patients who have unresectable disease, chemotherapy definitely has a role. This is in higher grade, again, grade 2 and grade 3. The overall survival at 3 years was about 60% for patients who received chemotherapy. Graph on the right shows that patients who received chemo, but then also got intraperitoneal chemotherapy did better. So the combination 3-year survival was about 73% compared to 50%. And we practice that. This is the trial that was mentioned in one of the other talks today, where we do iterative HI PEC. We do 3 cycles of HI PEC for patients, even if they don't have resectable disease, in addition to their systemic chemotherapy, to provide the best benefit to them. We have to carefully select those patients to make sure that those patients would benefit from this approach and can tolerate it. Goblet cell adenocarcinoma, I wanted to show this study over here to see patients who have undergone resection completely, who could benefit from adjuvant chemotherapy. And in this study, this is a recent study, they looked at multiple factors, including lymphovascular invasion, number of lymph nodes, margins, and all of that. Certainly margin negative disease was better, but the predictive factor from benefit from chemotherapy was lymph node positive disease. So if patient has goblet cell adenocarcinoma and has lymph node positive disease, we definitely offer chemotherapy in the adjuvant setting after the surgery. However, we have to keep in mind that this was a retrospective study. It was based on the NCDB database, and that does have limitations. So even in patients who have lymph node positive disease or negative disease, but I'm concerned, I would offer chemotherapy in that setting. As far as choice of therapy is concerned for patients, 5-FU or capecitabine makes the backbone of chemotherapy for all appendix cancer treatments, at least upfront. This can be combined with leucovorin. Leucovorin doesn't have an effect on treatment on the cancer itself. However, it can help make 5-FU, especially in the bolus form, more effective by helping it penetrate into the cancer cells. 5-FU or Capox or capecitabine can be combined with oxaliplatin. Those regimens are called FOLFOX or Capox. 5-FU can also be combined with irinotecan. That regimen is called FOLFIRI. I usually do not use capecitabine with irinotecan. I find that it's very, very toxic. So if I'm giving irinotecan, I like to do it with the 5-FU, which is the infusion. And then we can use 3 drug regimens as well, like 5-FU, oxaliplatin, and irinotecan, which actually is our preferred regimen at University of Chicago for patients who are able to tolerate. The more chemos I add, the more the toxicity. So again, careful patient selection is needed here. And then bevacizumab, it is an antibody which binds to the something called VEGF receptors, which helps blood vessels grow to the tumor. So the antibody binds to that and stops the growth of these blood vessels to the tumor. But bevacizumab has shown to improve survival in lower GI cancers. However, it does have side effects of bleeding, poor wound healing, as well as clotting. So patients who are going for surgery, my approach is to hold it at least 4 to 6 weeks prior to their surgical planned procedure to give them, to minimize that risk. And then if patients have progressed on these treatments and are still needing more therapy, our current standard of care is regorafenib and Lonsurf in those settings. But I think there's a lot of challenges as a medical oncologist managing appendix cancers. There's lack of well-controlled studies and data to guide the management. There is difficulty in measuring the disease, whether it's by imaging or tumor markers. Tumor markers are not always positive for appendix cancer. In addition, I think novel therapies are needed and novel ways are needed to help us measure the disease, to help generate those data so we feel we're giving our patients the best therapies. For these reasons, as has been mentioned previously, I think getting at least an opinion from a high volume center and perhaps getting treated at a high volume center is very important, not only for the skill of the surgeon or the medical oncologist, but also to benefit from the experience of the radiation oncologist, the radiologist, and the pathologist, and have an opportunity to participate in research. Participation in research may not help that patient, but it will help contribute to the knowledge in the field and help future patients. These are some of the unanswered questions that I think of. Is more chemo better? What is the appropriate regimen that I start a patient with, and how do I sequence that therapy? And what about targeting therapy? How about personalizing therapy for appendix cancer for patients? Is there really a role of radiation or immunotherapies in appendix cancers, as we are seeing more and more in some of the other cancers? And then how do we measure and monitor the disease better? Some of the ways we use is by molecular profiling. What does that mean? So what we do is take the DNA of the tumors. We take the tumor, we sequence out the DNA, and then we look at what mutations there are. All tumors have mutations. We are looking for mutations that can help us understand the tumor, meaning this is the mutations that's making the tumor grow. And is there an intervention available to help stop that process? This can be done on the tumor itself, so a biopsy or a surgical specimen. And there's also the liquid biopsy, what does that mean? When patients have tumors, some DNA is shed into the circulation, and that DNA then gets picked up by these assays and sequenced out. One of the challenges with liquid biopsy in appendix cancer is the shedding may not be as much because they're contained in the peritoneum. And so if a test is positive with the liquid biopsy, that helps us. But if a test is negative, we always wonder if it's because we didn't have enough shedding of the DNA to pick that up in the liquid biopsy. I'm borrowing this from colon cancer data. So colon cancers are different than appendix cancers, but I wanted to mention how we are personalizing therapies in colon cancer and how we can open this avenue up for appendix cancer treatments. These are some of the subtypes of colon cancers that actually are in clinical practice currently. Who can benefit from immunotherapy? We do some of the testing to see these are the patients we can identify and they will benefit from immunotherapy. Some targeted therapy like targeting BRAF or HER2. There is new targets with KRAS G12C. We identify these personalized approaches for patients, and we have medicines that we can give to patients, and we know that they would benefit from it. We have evidence that they would benefit from it. These are looking at the appendix cancer sequencing. So this column over here is the appendix cancer sequencing. In this paper, they sequenced out 183 appendiceal adenocarcinomas, and they actually compared the mutations to colon cancer, both right and left-sided. And there are differences. So BRAF mutations are way more common in right-sided colon cancers as compared to appendiceal or left-sided cancers. APC mutations are way more common in all colon cancers and very infrequent in appendiceal cancers. And then KRAS mutations are quite common in appendiceal cancers and a little less so in colorectal cancers, both right and left-sided. I think this shows us definitely that appendix cancers are not colon cancers. Appendix cancers are distinct from colon cancers, and that therapies and investigations have to be personalized to appendix cancers rather than some of the approach of extending those data to appendix cancers. And again, highlighting the need for investigation and research in appendix cancers. how can we use those data from molecular studies? I wanted to highlight some of the initiatives here. So as was mentioned, I'm involved in Alliance for Clinical Trials in Oncology, which is one of the NCI's cooperative groups. NCI had a study called the MATCH, where they identified mutations, and if there was a drug available for that mutation, regardless of the tumor type, a patient could go onto the study and see if the drug would benefit. This was a signal finding study for all those mutations. The next initiative to that is called the Combo Match. It is combination based on a biomarker. So if there is a mutation, can there be two medicines that we can combine that would help target that mutation better? Or can we combine it with chemotherapy and see if we can target that mutation better? I'm quite involved in that, both for operations as well as the scientific end of things. And we anticipate that we're going to be able to open the first 9 or so studies by spring or early summertime next year. This is one of the ones I'm involved with. This is looking at KRAS mutated tumors, and there are different cohorts to it. Cohort 1 and 2 are for ovarian cancers. Cohort 3 is for pancreatic cancers. And then cohort 4 is tumor agnostic, which is where I anticipate I would be able to offer therapies to my appendix cancer patients under that cohort 4. The reason pancreas is on its own is because about 95% of pancreatic cancers are KRAS mutated. So we did not want the whole cohort to be filled by pancreatic cancer patients just to get it to see what kind of signals we're getting in other tumors. These are signal finding studies, but hopefully would be available very soon to our patients. Then I wanted to kind of go over a few more studies that are going on in other cancers and see what we can borrow from that for appendix cancers. This one is looking at immunotherapy. It's a vaccine against KRAS mutations and use of immunotherapy with that to see if we can get responses in patients. These data were reported earlier this year, just actually last month. It's a small subset that was reported, about 12 patients, and it showed that patients did have a response with this kind of approach. And I think there was another key finding here, which is looking at which patients had a response. They did, in this study, they did liquid biopsy panel, and they followed the mutation. So not just whether the patient has a mutation, but how much, and then is it decreasing, is that allele frequency decreasing with treatment? And for patients who the allele frequency was decreasing, actually had a survival benefit compared to those it wasn't. So it was a good way to see how we can monitor the patients who are responding to our therapies, maybe even early on. This is not in practice currently. This is, a very early study, early results, but there is more being developed by that same approach in other cancers as well as in lower GI cancers. Next couple of slides are use of immunotherapy and TKI therapy, a targeted therapy for patients in lower GI cancers. Again, very small subset of patients, only 32 patients that have been reported, but there is a larger study ongoing currently, and we await the results to see if this kind of approach could be beneficial and maybe even new standard of care for patients if it does in fact show a response and improve outcomes for patients. This is the pembrolizumab study. This is pembrolizumab compared to either regorafenib or Lonsurf for patients, which would be the standard third-line treatment after chemotherapy. We had this study open. It's actually getting closed pretty soon at the end of this month. But the next one we will be opening soon, it's not open currently, is use of 2 different kinds of immunotherapy agents in lower GI cancers to see if they benefit. This study is only for colon cancer patients, but certainly, hopefully, we can use these approaches for appendix patients in the near future if there are signals. And KRAS G12C targeting, I think I mentioned that briefly. Here, this codebreak study was also reported at ESMO this last month, so just in September, where KRAS G12C inhibitors that target one specific type of KRAS mutation were combined with EGFR therapy, something called cetuximab or panitumumab, and there was a response seen. Response was not seen just with the KRAS inhibitor. And so this shows that in, and in other cancers, like in lung cancer, they did see a response with just the inhibitor. So one, it shows us that every cancer may be different. We can combine what we know from the tissue of origin and what we know from targeted therapies and come up with the best therapy options for our patients. The bigger trial for this is ongoing currently, and it is open at our institution. So we will see, hopefully that big trial also shows a lot of responses. And then the last couple of slides I have are looking at the ctDNA, which is the test I had mentioned previously. Here, what they do is that they measure out the amount of DNA that a patient has circulating in the blood. Then there is a proprietary way to identify that this DNA is only coming from tumor and not coming from any other source from the patient. And then not just it's there, but also it's there and how much of it is there. And then you measure it after surgery at multiple time points. And if it's 0, that's meaningful. If it's going up, that's meaningful. And how fast is it going up? All of that is meaningful. And again, research is going on in that field to understand, exactly what those numbers are. This particular study looked at longitudinal ctDNA measurement as well as the CEA. And it shows that CEA is something that predicts, so as CEA rises, we can tell that the patient would have recurrence. But the ctDNA measurement outperformed the CEA, so maybe a little bit better test. Same study looked at CT scan findings as well. So each green dot here represents a patient, and when their CT scan was positive compared to the ctDNA was positive, and many of the patients have the lines going upwards from the green to the blue, which show that the ctDNA was positive before the CT scan was positive. This was a European study. The lead time here was about 8 months. The scanning frequency in Europe is different than what we do in the United States. So our lead time, if we did the study here, may not be 8 months, maybe less than that. But it still shows that ctDNA and this kind of novel technique can pick up disease in a hard to measure cancer early on compared to just measuring tumor markers or CT scans. Again, caution here because appendix cancers may not be shedding as much DNA. So if it's negative, that does not mean that the patient doesn't have disease. It may also mean that it's just not enough DNA in the circulation to pick it up. And I think that was my last slide. So in conclusion, we did talk about, this is a new era of discoveries for lower GI cancers. There's a lot of novel approaches and novel ways that we are doing that we are investigating. I think sequencing of available options, personalizing treatment, that is the new era. We have a lot of work to do in appendix cancers to get there, but I think a lot of efforts are in place for that. And this is my last slide. I want to thank all of our patients, our families, my colleagues, all the investigators and the organizing committee for their continued effort in improving research and improving outcomes for this important disease for our patients.
Thank you, Dr. Shergill. Up next, we have Dr. Votanopoulos, who is a professor of surgery at the Wake Forest University and a founding director of the Wake Forest Organoid Research Center, WFORCE. He completed his surgical residency at Baylor College in Houston, Texas, surgical oncology fellowship at Roswell Park Cancer Institute in Buffalo, New York. He is a recognized expert and thought leader on peritoneal surface malignancies with NIH-funded research, more than 180 publications, numerous podium presentations, and book chapters. Please welcome Dr. Votanopoulos.
Hello, everybody. Let me give you our latest update on our organoids and the personalized therapy. Allow me to spend a few slides so that everybody can be brought up to speed on some basic concepts. So what is a tumor organoid? The tumor organoid, how is it made, first of all? What you see in the screen is one of the first appendiceal cancers organoids that we built back in 2016. The way you have to think in your mind of an organoid is nothing more than a dissociated piece of a tumor that is dropped within a hydrogel system. And in 80% of the patients, we have chemosensitivity results and immunosensitivity results in about 5 to 10 days. And how do these results look like? They look like exactly this. So on the one side, you have different chemotherapy regimens or immunotherapy regimens. And on the other side, you have residual viability of the tumor at the end of the treatment. If red is dead and green is alive cells, the best treatment here is the one at the bottom that leaves only 11.8% of the tumor alive. Can we perfuse an organoid? We absolutely can. We can perfuse an organoid exactly as we perfuse a patient doing HI PEC. We place the organoids in these small wells at the center of the screen. We have inflow cannulas, outflow cannulas. There is a continuous flow through a peristaltic pump. And it is a very handy system because it allows us to map the experiment on real time. The big question was always, do we have clinical correlation? We know since 2018 from this paper that was published in Cell by Dr. Vlachogiannis that the organoids were showing they had an 88% positive predictive value and they had an 100% negative predictive value. That means that when the organoid was responding, the patient was to chemotherapy, the patient was responding 80%, 88% of the time. And when the organoid was not responding, the patient never responded. And this number is a very important number because it will allow us to find out what chemotherapy drug or what immunotherapy drug is not working for the patient. In this way, we can skip unnecessary toxicity and unnecessary cost. For example, on this slide, on the right side, you have a number of low-grade appendiceal cancers that were treated with chemotherapy and did not respond. And the same thing happened with the organoids. Can we select drugs for HI PEC? We absolutely can select drugs for HI PEC. Here on the green brackets, you see the impact of 2 hours of perfusion with mitomycin C over 1 millimeter of appendiceal cancer organoid. And what is left behind is 80% of the cells alive after 2 hours. On the other side, if you decide to perfuse the same tumor with the same organoid with oxaliplatin at the regimen that was used in the Prodigy 7 trial, at least 50% of the tumor is staying alive. So we can clearly identify what is a good drug for HI PEC and not what is a bad drug for HI PEC. Can we identify if hyperthermia is working for all? Well, I can tell you right now that not usually, the majority of cases, hyperthermia will potentiate the effect of chemotherapy, but there is a subgroup of patients, maybe about 50 to 10%, that hyperthermia will just add nothing. Because the drug, for example, mitomycin C, is quite often effective without heat too. And maybe in the future we can identify this subgroup and spare them from hyperthermia altogether. Can we customize both HI PEC and systemic chemotherapy? Yes, we can. On the left side, you see systemic concentrations for a low-grade appendiceal cancer. Oxaliplatin clearly is not a good choice, but when you take the same drug and you apply that drug in concentrations achieved by IP chemotherapy and hyperthermia, oxaliplatin automatically becomes a very good option for this individual patient. What about immunotherapy? Can we identify response to immunotherapy? It seems that we can. What needs to be done in this case is we need to introduce an immune system, a patient-matched immune system within the organoid. So we take immune elements from the individual patient and we co-culture them with the tumor, and then we hit them with immunotherapy. Immunotherapy for appendiceal cancer works in less than 20% of the patients, at least at the organoid level. When it works, it really works well. But it will be extremely beneficial if we can pinpoint exactly who will be the patient that will benefit from immunotherapy and who is the patient that we should not be treated with that. Why the above are important? All of the above are important because it will allow us to study questions like clonality, like what we in the past we were calling as heterogeneity. And what is that? When the patient with carcinomatosis or with peritoneal surface disease has a good amount of tumor in the abdomen, then very rarely you have a single population of cells within this peritoneal cavity. And this slide here depicts exactly that. These are tumors removed from the same patient during the same procedure from different areas within the abdominal cavity. The patient had the tumor removed from the ovary, from the appendix, from the left hemidiaphragm, and from the liver capsule. Organoids grown from all of those were treated with the same conditions and the same drugs. And every tumor from each side were responding to the same drug differently. So this is an extremely important concept. And I'm going to reinforce that idea with the following slide. This is the 8 appendiceal cancer cell lines that were created from the same patient, from the same lesion. So we took a piece of the tumor from the same patient. We processed it to create appendiceal cancer cell line, and we create 8 of them out of the same lesion with different subclonal variations within each one of them. So that gives you an idea of what's happening within an individual patient. That gives you an idea of how many different tumors were fighting at the same time. And this is something that will have to alarm us, and it has to make us think slightly different. It's a time for a concept change, because if we have that level of clonality within the same individual patient, and we have heterogeneity between different patients, a clinical trial that utilizes cohort analysis is just not enough. It will never be able to depict what is really happening within patients, maybe within a cohort, but we never will say what will happen within an individual patient with accuracy. And we need to design research tools to approach every individual patient separately. What we are working for and what we are hoping to achieve is to reach a point that we can map upfront the tumor clonality for every individual patient that comes to the clinic. We need to be able to match available treatments to specific clonal subpopulations, and then we need to determine the treatment of choice, the duration of each treatment, and the sequence of different treatments. And I know that probably that sounds like a daunting task, but we need to do some reflection, and it's time for the reflection slide here. And I would like to remind you that, quite often we overestimate what we can achieve within a year or 2 years, and we underestimate what we can achieve in 5 or 10 years. So here we are back in 2016. 2016 was when we first generated the first appendiceal cancer organoid. 5 years later, we have generated organoid platforms to study response to systemic chemotherapy 1, 2 IP chemotherapy, 3 immunotherapy, and 4 hyperthermia. We have an appendiceal cancer cell line, and we got 2 NCI-R01 grants on peritoneal disease, and one of them is totally dedicated to appendiceal cancer that NCI has never funded before. So things are moving, things are looking promising. We are progressing fast and towards the right direction, but nothing of that could have been done without the support of all of you and the ACPMP. With that, I would like to acknowledge, our patients and the families, our Wake Forest Cancer Center, the Surgical Oncology Division, the WFM, the ACPMP itself. I have to say that the cancer cell lines that we have created, it was totally funded by ACPMP. And today, they are available for any researcher who wants to do classic research on appendiceal cancer. The only thing they can do is they can email me, and we're going to forward the lines to them. With that, I will conclude, and I'm going to be waiting for your questions. Thank you.
Thank you so much, Dr. Votanopoulos. Up next, we have a special guest presenter from the City of Hope Medical Center located in California, and that is Dr. Rauf. Dr. Rauf is a surgical oncologist and assistant clinical professor, as I said, at the City of Hope Cancer Center. He focuses on the surgical treatment of cancers within the abdominal cavity, particularly those from the liver, bile duct, pancreas, and gastrointestinal tract. Dr. Rauf conducts laboratory research focusing on DNA repair mechanisms in cancers, and his mission is to deliver complex surgical oncology care with expertise and compassion, as well as to develop new therapies for patients with GI cancers. Thank you so much, Dr. Rauf, for joining us today, and we look forward to your presentation.
Thank you for inviting me today to speak at the Appendix Cancer Survivorship Symposium. I will be giving an overview of the PIPEC and the management of appendiceal cancers. So in the next 10 minutes, my goal is to introduce the concept of PIPEC and rationale for its use in appendiceal cancers. I would like to discuss PIPEC procedure, and then I would also like to give an overview of the US PIPEC trials and eligibility. So the rationale for PIPEC and appendiceal cancers, everyone knows here appendix cancer is rare. about 1,500 cases per year in the US. 32% of patients will present with appendicitis. And at the time of diagnosis, half of the patients will already have metastases to the peritoneum, and many others will have other distant metastases. Appendix cancer is a spectrum, starts from normal duct to hyperplasia to dysplasia to invasive carcinoma. And all of these have been, there have been names associated with each category. And this is one condition where even non-invasive type of cancer can be life-threatening. We all know that high-grade disease has the worst survival, and low and moderate-grade disease tend to do better. For low-grade neoplasms or low-grade adenocarcinomas, cytoreductive surgery and heated intraperitoneal chemotherapy has become the standard of care. And when patients are managed this way, we can ensure excellent long-term survival for these patients. For high-grade disease, on the other hand, this remains a significant challenge. We typically see early recurrences in patients who are treated with cytoreductive surgery and HIPEC, and most centers at this time will introduce some form of chemotherapy before selecting patients and taking them for a major operation. Most patients will also require postoperative chemotherapy. When patients are managed in this way, this is very typical of the survival curves that we see. Patients who've had a complete cytoreduction, HIPEC, perioperative chemotherapy, their median survival can be as high as 4.2 months. This series from MD Anderson Cancer Center. Patients who never go on to complete cytoreduction or have just treated with systemic therapy or incomplete cytoreduction have a median survival of about 1.7 years. So these are the challenges that we see. So we need therapy, a therapy that can downstage patients, meaning more patients can be candidates for cytoreductive surgery. We also need a strategy to better select patients who will be well suited for any form of cytoreductive surgery. In chemorefractory setting, where patients are not resectable and they've been treated with 1 or 2 lines of chemotherapy, better therapies are needed, and we need an intervention that could improve survival in that setting as well as quality of life. And then in the post-resection setting, a therapy that can potentially prevent recurrences can potentially also improve survival, and therapies are needed in that space as well. So PIPEC is a novel approach to treat patients with peritoneal metastases. This is a laparoscopic procedure where abdominal cavity access is established as shown using trocars, and then chemotherapy is introduced as if to fumigate the abdomen with chemotherapy. And so looking back at the data that has led to the development of PIPEC, this is a swine study where in the swine model, aerosolized methylene blue was given, and you can see all surfaces were stained with methylene blue. When these animals were compared to those that had the PIPEC, T1 and T2, compared to the control model, which was treated with methylene blue lavage, we could see more deposition of methylene blue in the PIPEC arm. And more recently, there's been a study comparing HIPEC and PIPEC in terms of distribution of the chemotherapy. These investigators divided the abdominal cavity into 10 sections, and the HIPEC was given at a dose that is used clinically, 75 milligram per meter square for 60 minutes, and PIPEC was given at 7.5 milligram per meter square. As you can see, HIPEC results in more platinum distributed, but when you look at the dose that was used, given that the dose in PIPEC was 10-fold lower, the yield of tumor deposition is much higher with PIPEC, and the systemic concentration as a result is much less compared to what is achieved with HIPEC. So we want less drug in the systemic circulation to minimize toxic effects. So PIPEC has now been used in several studies. Worldwide, this is a report as of 2019, and several thousand additional procedures have since been done. But in this report, they summarize the findings from the first 1,800 procedures in 838 patients across 45 clinical studies. In this summary of heterogeneous patients, what we find that 64% of patients will undergo at least 2 PIPECs. The adverse event rates were low, 12 to 15%, which is much lower than systemic chemotherapies, which are on the average of about 30% or higher. And the objective response rates measured through several different criteria, ranged from 60 to 70 to 80% across different disease types. Now, the way we measure response is up to debate, and so it's not clear as to what that response means in terms of the traditional measures of measuring response, like RECIST criteria that we use radiographically. So this is a landscape of the ongoing PIPEC clinical trials through the clinicaltrials.gov website. And we see that there are many trials in different GI malignancies as well as gynecologic malignancies, majority of them investigating the 2 regimens, which is either cisplatin plus doxorubicin, and the other regimen is oxaliplatin. Some of these studies, like the PIPEC ESTOK-01 from France, is a randomized trial comparing systemic therapy versus systemic therapy plus PIPEC in first-line setting for gastric cancer. And similarly, Mesotip is also a randomized trial from France. So the advantages are, this is a minimally invasive technique. It's repeated every 6 weeks or so. It's ambulatory surgery. Patients typically will leave the hospital the next day or the day after. High dose of therapy delivered directly to the most threatening tumors, especially those involving the small intestine, which can cause obstruction. There appears to be high tumor penetration due to pressure in preclinical models, and the studies thus far on quality of life, although limited, have shown that the quality of life is preserved through the course of PIPEC treatments. So let me go over the PIPEC operative setup. I've shown this picture before. On the screen right, you will see the injector, and the tubing connects from the injector to the capnopen, or the aerosolizing device, which is placed in one of the trocars, as you can see over here. And usually before the trocar is placed, we establish abdominal cavity access. And we do this using the techniques published by Glatz. Basically, a 3 centimeter midline laparotomy is first created in the center using the Hassan technique. It's a more generous Hassan incision, and then the rest of the ports are subsequently placed under vision. This is necessary because carcinomatosis usually will cause a lot of adhesions to the anterior abdominal wall. And if there's a serosal injury or an enterotomy created at the time of the PIPEC procedure, usually we will need to delay or abort the PIPEC procedure because the risk of enteric leak in that setting is significantly high and prohibitive. After the access is established, we proceed with the survey of the abdomen. We calculate the carcinomatosis burden. We evacuate the ascites and collect it for research studies. Then we proceed with performing 4-quadrant biopsies of tumor as well as normal samples. We use balloon trocars to create an adequate seal so the aerosol chemotherapy does not leak into the operating room. There's 3 levels of safety that we ensure, which I will not be able to cover in this talk. Once the samples are collected, everybody leaves the operating room, and you can see our anesthesiologist across on the other side from the door. And you can see the PIPEC injector with 2 types of chemotherapies loaded. In this case, it's cisplatin and doxorubicin. And the tubing comes on over the drapes to the patient, and the capnopen is injected in one of the trocars. The monitors are facing the substerile room where the anesthesiologist can remotely monitor the patient. And you can't see the IV access, but the anesthesiologist has the IV access remotely, and the injector is activated remotely as well. So this is the screen, how it looks like when the injector is activated. And this is the loading of the chemotherapy agents on the injector. This is a conventional injector that we use for CT contrast injection during CAT scan images. So the air slicer can air slice a wide range of materials, including nanotherapeutics, oncolytic viruses, and such. And it has many research uses at this point. Once everybody leaves the room, we are then able to press a button remotely and activate the aerosolization. It takes about 5 to 6 minutes to aerosolize the chemotherapy, and we let it precipitate for 30 minutes. And then the pneumoperitoneum is evacuated, at which point we take post-PIPEC biopsies and the procedure is completed. So the first US clinical trial was 2-arm trial. Arm 1 included ovarian, uterine, and gastric cancer patients, as well as soft tissue sarcoma or DSRCT patients. And Arm 2 included colorectal and appendiceal cancer patients. As you can see, the arms are decided based off of the chemotherapies we're using. In case of colorectal and appendiceal, the first PIPEC only had oxaliplatin, 90 milligram per meter square, whereas in PIPEC 2 and PIPEC 3, we were using a sensitizing dose of 5-FU leucovorin at 400 milligram per meter square. This is borrowed from the French studies demonstrating sensitization of intraperitoneal oxaliplatin when given with low-dose 5-FU and leucovorin. The primary objective of this trial is to establish the safety. We are not dose escalating. We're essentially establishing the safety in the US setting. This trial is also allowing us to develop a collaborative approach to doing PIPEC and laying the foundation for future trials as well. So in this trial, we're using 90 milligram per meter square of oxaliplatin. We measure dose limiting toxicities for up to about 6 weeks, and adverse events are monitored for 18 weeks. And then during these time points, we are collecting tissue as well as blood for translational studies. So to date, so this trial is in collaboration with Northwell, Mayo Clinic, and NCI. We have accrued 6 out of 11 patients in Arm 1 and 9 out of 11 patients in Arm 2. So this is exciting because for the first time, we are able to longitudinally evaluate patients' tumor and look at changes in subclonal evolution, genomic heterogeneity, as well as the tumor microenvironment. We are conducting pharmacokinetic studies and tumor penetration of the chemotherapy, and we are also evaluating some novel circulating biomarkers to see if we can improve on the current yield and sensitivity of circulating tumor DNA and other types of analysis that are available. So going forward, so the trial I just presented before was in the chemorefractory setting. Patients should have had progression on 1 or 2nd line chemotherapy. Most patients in the trial that were accrued have had progression on 2 lines of chemotherapy. The next trial is moving PIPEC up in terms of therapy. We are including patients who are not yet chemorefractory. They should have been treated with at least 4 months of 1st or 2nd line chemotherapy, and they're not candidates for cytoreductive surgery. This is a dose escalation trial. The choice of chemotherapy here is mitomycin C. There are other phase 2 trials happening in this space with oxaliplatin. So this trial is different from the other trials. For the first time, we will be formally investigating mitomycin C in the PIPEC setting. Mitomycin C is the drug we most commonly use in the US for treatment of appendiceal cancer with cytoreductive surgery and HI PEC. And so in this study, we have 4 dose levels, and patients who are treated with at least 4 months of chemotherapy will be allowed to be enrolled. We exclude patients who have distant disease or who have bowel obstruction. Prior chemotherapy should be per standard of care. And the interesting or novel aspect of this trial is that we will be combining FOLFIRI systemic chemotherapy with mitomycin C, and we will be testing the feasibility as well as safety of doing a combined approach in this fashion. And again, we will be collecting tumor samples as well as blood through the course of the study to evaluate biomarkers and other translational objectives. So this is the City of Hope PIPEC peritoneal surface malignancy team. I'm very grateful to be funded through several organizations, both for appendiceal cancer work as well as my pancreatic cancer research program. I am happy to
Thank you so much, Dr. Votanopoulos. It seems like the connection was cut there, so apologies to everyone viewing. So we are running a couple minutes behind, so we'll just keep on schedule. And up next, we have Dr. Hay. Dr. Hay is the John T. Wilson Distinguished Service Professor in the Department of Chemistry and Department of Biochemistry and Molecular Biology at the University of Chicago. His research spans a broad range of fields, including chemical biology, RNA biology, epigenetics, biochemistry, and genomics. His work is foundational to developing potential therapies that target RNA methylation effectors against human diseases such as cancer. So please welcome Dr. Hay with the University of Chicago.
All right, thanks for the opportunity. Today, I'm going to introduce epigenetic biomarker discovery from plasma cell-free DNA. So this is a project that we've been working with Dr. Turaga from University of Chicago. Dr. Turaga is a physician really working on peritoneal metastasis. This metastasis can come from colorectal cancer, appendix cancer, or ovarian cancer. And whenever you have this cancer from primary tumor site, they can spread to peritoneal, and there we need biomarkers for diagnosis, prognosis, and importantly, after surgery, we need the biomarker to monitor reoccurrence. The early we can monitor the reoccurrence, the better chance for patient to survive. And the current biomarkers, but as you can say, they don't really work that well. They're good, but not ideal. And our hope is to discover and apply more accurate or more sort of sensitive epigenetic biomarkers. The program is built upon a previous discovery made in my laboratory that we figure out a way to label hydroxyl methyl C on DNA with biotin. So this enables us to enrich and globally mapping hydroxyl methyl C, a sort of a very interesting epigenetic biomarker from genomic DNA, from fresh FFPE tissues, or importantly, from circulating cell-free DNA directly from blood and plasma. We've showed that previously. This is actually a work we published last year in which we did 19 human tissues. We mapped hydroxyl methyl C from genomic DNA isolated from human tissue. And this results really showed you that these hydroxyl methyl C biomarkers are very good at differentiating different tissue types. And importantly, we build this whole body human tissue map. So whenever we see a hydroxyl methyl C signature from tissue or from blood, we know exactly where it comes from. So this is sort of a figure to show you that there are these hydroxyl methyl C modified genes that are very much tissue specific. So to extend the study, we also try to work on the cell-free DNA. So these are DNAs coming from different tissues, cell die. They release this DNA into the blood, and we can use a few mils of blood to capture this DNA, perform the sequencing method. We know exactly where the cell-free DNA come from, which tissue, and importantly, if it comes from tumor, we can detect that at the early event. So again, as I said, this is really a collaboration between many labs. Dr. Turaga's lab drive the entire thing. Marc Bissonnet, colorectal cancer physician, Dr. Wei Zhang from Northwestern, our bioinformatics, biostatistics expert, and my own lab, we provided the method and execute experiments. And there are many, many researchers and clinical side have been involved in this work. This is a preliminary pilot study we were excited about. So here we can look at the peritoneal metastasis versus control, and we can also look at the peritoneal metastasis from different tumor site. And we can clearly say we can separate these groups with hydroxymethyl C biomarkers. So we're confident. This gives us the confidence to move on with this project. So Dr. Turaga's laboratory collected over the last couple years 226 samples with different categories. And we came in to isolate the cell-free DNA and perform the sequencing, and we're in the process of performing analysis. And I have to say that the pandemic has caused a major delay and the interruption of this. And unfortunately, we're back and we're trying to move this forward. With this 226 sample and analyzed, we think we have a baseline to move on to clinical trials. And indeed, we're currently in the process of Dr. Turaga's laboratory are in the process of collecting samples from for future clinical biomarker discovery. We not only have this peritoneal metastasis detection, but also after surgery, they're collecting at different time points to really provide a sensitive marker to monitor peritoneal metastasis reoccurrence. As I said, this is a critical factor. If you can capture recurrence early, the likelihood to treat the patient is just much higher. In addition to hydroxymethyl C, DNA methylation is also a well-known biomarker. You probably heard news from Gorilla, Exact Science. DNA methylation and hydroxymethylation are sort of complementary to each other. DNA methylation is more stable, easier to detect. However, the problem has been that you need a large amount of DNA in order to detect the DNA methylation, just because the method, the so-called bisulfite sequencing, leads to a lot of degradation of DNA. So you typically need 10, 20 mL of blood. We recently developed this new method we call a linear amplification-based bisulfite sequencing, or LabSeq, which has unprecedented sensitivity and comprehensiveness in terms of 5-methyl-C mapping from genomic DNA or cell-free DNA. Here's the procedure. We basically take a cell-free DNA, fragmented genomic DNA, and we put a T7 adapter. So what this means is later on, after bisulfite treatment, we produce RNA first. So this is the linear amplification to produce RNA first, and from this RNA, we then produce DNA. Now, this step avoids the exponential amplification. So the linear amplification best keep the original information. So this method is base resolution, whole genome, unbiased, and most importantly, we only require a nanogram or less. The traditional methods require something like a 20 nanogram in order to get a comprehensive information. And as you guys know, if you draw 20 mL of blood, it's just not as friendly to the patients as well as to the physician. In this particular case, we don't even need 1 ml of blood. This is sort of the results compared to commercial kits. These are 5-methyl-C bisulfite sequencing kits you can buy from commercial vendors. This is our LabSeq results. As you can see that when we drop to 100 picogram, we still have very good genome coverage. That means we can still cover a large amount of human genome, but then with commercial method, you don't see anything, the green one, right? This is probably more direct way to view this. This is just we pick the part of the genome to show you the coverage. Each of these lines is just one data point. Now with commercial method, if you use 100 nanogram, you get very good genome coverage. Okay, this is considered a very good data. If you go down to 1 nanogram, you see very sparse coverage. Most signals are gone, right? If you go to 100 picogram, you barely see anything. This is another commercial kit. Again, at 1 nanogram, you have the sparse coverage of the human genome. Now look at our LabSeq. This is the real results. 1 nanogram coverage is even better than the 100 nanogram from this commercial kits, all right? We can drop down to 100 picogram, we still keep pretty decent coverage. And right now we use 500 picogram to 1 nanogram, which is roughly 0.5 ml blood or less. So this is really, we believe, most friendly way for us to uncover pharmaceutical biomarkers, and we're going to apply this to all the samples we collected so far. I want to finish, I know this is appendix cancer group, so I want to just say that we also have done pilot studies to look at the colon arranging versus appendix arranging. So with appendix cancer, with metastasis to peritoneal, we can easily or readily separate from other and from healthy controls. So whatever we learned during this process can be readily applied to the appendix cancer, and we're collecting those samples at the moment. So that's it. I want to thank you for this opportunity again.
Thank you so much, Dr. Hay. As I've stated, the symposium is running a little bit behind schedule, so we are going to cut to our lunch break right now, which will be about 15 minutes. We will restart at 1 o'clock and continue on with the rest of our presenters. I just want to reiterate that you can submit any questions through the Q&A feature at any point during the symposium, and we will get to them during the open forums. And also I want to let you all know that the entire symposium, the general session, and the 3 regional sessions will be completely recorded and available to view afterwards. The link that you use to register, acpmp.org/virtual symposium 2021, is where we will be posting all of the recordings. Again, we're going to cut to a lunch break right now until 1 o'clock. So we hope to see you back at 1 o'clock. Go have something good, get up and stretch your legs, and we'll see you all soon. Thanks. everyone, and welcome back from the lunch break. I hope you all have enjoyed the general session so far. We are back on schedule, but we do have a couple of adjustments to the agenda moving forward. Up next, we will be having Dr. Weiss from the University of Chicago come on, and you will hear from Dr. Harmoth after Dr. Levine's talk right before the Nutrition and QOL Roundtable. The Nutrition and QOL Roundtable will now be 20 minutes instead of 30 minutes. So that is another adjustment. So I want to welcome Dr. Randy Weiss. Dr. Weiss is a medical oncologist at the University of Chicago with an expertise in the development of new cancer immunotherapies. He's going to be talking about the latest for immunotherapy for solid tumors.
Thank you for that introduction. It's a pleasure to be here and to share some exciting new areas of research. Let me just share my screen. I have some slides to guide us the discussion. All right. So hopefully that's visible. So the topic of my talk today is on updates on immunotherapy of solid tumors. I focus on immunotherapeutic development in phase 1 clinical trials for solid tumors, and I do research in a laboratory investigating resistance to immune therapies. So these are updates, but I'd like to start over a century ago where this topic really became of interest. This gentleman is a physician named William Coley, who was alive in the late 19th century, early 20th century. And he was a surgeon in the New York area who was working on, who would see lots of patients with sarcomas and would undergo these surgeries to resect sarcomas, and was just frustrated by the recurrence rates, and that patients would come back and die from their cancer, unfortunately, in spite of his efforts at removing these things surgically. So when an initial observation was made that some patients who developed bacterial infections after surgery actually seemed to have a higher rate of cure or higher chances of the cancer not coming back. So he made the connection that perhaps the immune system, the immune response to the bacterial infection, was actually having a secondary benefit in that it was able to control the cancer. And so this is really when probably one of the first major links between cancer and the immune system against were connected as a potential therapeutic. So he took it a step further and said, I'm going to actually inject patients with a bacterial concoction that was now we call Coley's toxin. He actually made in the lab and treated patients by direct injection of bacteria into these cancers. And in fact, reported 12 patients to be cured of this group, that some of which were injected intentionally, but others who developed infections incidentally after surgery. Unfortunately, this was prior to the era of antibiotics, and this was sort of an aggressive maneuver, and some patients developed sepsis and died from the infection itself. So this concept fell out of favor somewhat for many, many decades, and especially as chemotherapies were developed and radiotherapy techniques were developed. And the concept kind of fell out of favor for decades until more recently. So I just want to give a brief overview. I don't want to get too much into the weeds, but to understand how cancers can be recognized by the immune system. And effectively, what can happen is tumor cell abnormal proteins can be seen by these immune cells that we call antigen-presenting cells or dendritic cells. They see these abnormal proteins in tumors, and they can actually trigger T cells, which are the cells that actually can do the killing of the tumor cells. They can actually trigger the growth and activation of those cells, which can circulate back through the circulation, find the tumors and kill them. Now, clearly, patients who develop cancer, in spite of this theoretical framework, so there must be defects somewhere along this pathway that allow cancer to grow. And one of the most important discoveries of the last 20 years has been the identification of what I call brakes on the immune system, and the fact that tumors can exploit these brakes, these proteins that are we call checkpoints, that can actually shut off the immune response and allow the tumor to grow. And this is a depiction of that. So tumor cells can express this protein called PD-L1, which is at one of these breaks. And when the T cells that normally would want to kill the tumor cell see that protein expressed, it gives a signal to shut off. So you get these negative signals I'm showing here. There's another break called CTLA4 that similarly can shut off T cells and other immune cells. And so the taking it to the next step, the therapeutic development over the last 15 years has been, around blocking these checkpoints. So what we call immune checkpoint inhibitors. These green antibodies are shown as the drugs that we now have in our toolbox to kill cancer. And they actually work not by killing cancer directly, but by unlocking this immune cell response. And I like to tell patients this is basically the drugs cut the brakes and allow the T cells to do their work and kill the tumor. So this is seems quite simple, but actually took decades of research to understand these interactions, and in fact led to the Nobel Prize in 2018. Jim Allison here in the United States, starting at Berkeley and then now at MD Anderson in Texas, discovered that blocking the CTLA4 pathway could be used as a cancer therapeutic. And Tasuku Honjo in Japan similarly really pioneered the use of antibodies blocking PD-1 as another immune checkpoint. And both of these are now used in drugs that we have today for cancer. And I wrote a book chapter in 2017 outlining the use of these negative regulatory blockers or checkpoint blockers. And the FDA approvals at that time are shown here. As you can see, these strategies are working across many different cancers. But what's amazing is that I just updated this chapter for 2021, and this list has now grown probably triple or quadruple in size in terms of the number of cancers that we are now treating with immune checkpoint blockers. And it's gotten so small you can barely read it here. So that's great progress. But unfortunately, what we know is that some patients have cancers that are still resistant to blocking checkpoints. So we're trying to understand why some tumors don't. And appendix cancer has actually been a challenging one in terms of immune therapy, because we know that even before you start treatment, some tumors, when you look at them under the microscope and you measure immune cells and other cells that are present, some have this type of phenotype where you see the proliferation, the growth, and tumor cells growing rapidly without any reaction by the immune system, even before therapy. But some, even before you give the immune therapy, they have this sort of pre-existing immune response. We call them T cell inflamed, but it's not functional enough. And so the cancer still grows. But when you give the checkpoint blocker, it can actually cause these cells to start working. And those patients that have these type of tumors tend to have better responses. And colorectal cancers and appendix cancers tend to be more of this type on the left, which is harder to treat with immune therapies. And that's where our efforts are now focused on trying to develop new drugs. And so when you think about why tumors have these different immune responses, or why the patient's immune systems respond differently to tumors, there can be three general categories of effects. And one can be perhaps the patient's immune system that they're born with. Some are more likely to react strongly to a tumor, some are not. So inherited genes, which may be things that we can actually modulate in the future with different therapies. Or it could be the tumor itself has figured out other mechanisms to block the response. And then certainly there are other things like diet, the probiotic microbiome that is present in the body that can interface with the immune response, that can influence in a good or a bad way the immune response against cancer. So in order to circumvent some of the other resistance pathways, there are new strategies that we're developing. And really, they're aimed at inflaming these non-inflamed tumors, as we describe. And some involve, we have a number of clinical trials now doing direct injection into the tumor. So rather than giving an IV drug or a pill, we're actually using either things that we can do directly in the clinic if they're close to the surface of the skin, or we have establishing protocols with our interventional radiologists that can inject deeper lesions. Or even our surgeons who can go in and do some procedures that might inject tumors directly with agents that essentially inflame these tumors, that can convert the immune response to more of an inflamed tumor. And there's a whole long list of these drugs that are in trial development now, and we're hoping that some of these strategies will pan out. Secondly, there's a new category of therapies that are what we call bi or trispecifics. And what that means is you have a drug or a protein scaffold that basically can connect with two things. So you have an antibody that can say here on the top, this is connecting with a tumor antigen. So it's actually the drug recognizes one of the abnormal proteins that tumors make. And that can be any protein you design it to target. And the other end of it that's connected actually connects with T cells or immune cells that I said are good for killing tumors. So this literally mechanically will draw T cells towards the tumor, and we inject this IV or subcutaneously, and it sort of circulates throughout the body, and it can actually lead to immune responses in tumors that haven't historically had immune responses, or those non-inflamed tumors. There's a drug that has a positive phase 3 that is likely to get approved in uveal melanoma very soon, a disease in which typically doesn't respond to those immune checkpoint blockers. So this strategy is working. These other ones on the bottom are similar. One might envision an antibody that binds a tumor protein, but is connected to a chemotherapy. We call those antibody drug conjugates. And there are a number that are FDA approved now that actually can deliver chemotherapy in a smarter way directly to the tumor, so you get less side effects and also maybe have better tumor kill. And this has actually been successful in many cancers like breast cancer and urothelial cancer, bladder cancer. You can also connect it to other antibodies that pull in different immune cells or whatever target of interest. This technology has really been developed over 20 years to target 2 or 3 things, maybe hit more than one immune checkpoint. As I said in the beginning, there are actually more than one of these breaks, and so maybe blocking a couple or 2 or 3 of these breaks at the same time can be helpful. And then lastly, CAR T cells, which I have a next slide on, which shows bypass all of these blocking steps that cancers can exploit by simply taking a patient's own T cells or immune cells and modifying them in the laboratory to be hyperactive against a particular tumor and then injecting them back in. And this has been very successful and now approved in hematologic malignancies like lymphoma, leukemia, and is moving quickly into solid tumors. And we hope to see success in solid tumor cancers there too. This is quite impressive. This is basically a living drug that is your own immune system that's modified and can actually stay alive and continue to surveil for cancer in the body afterwards. So that's a third strategy. So really, in summary, it's I don't have a lot of time. I'd love to go into a lot more detail, but in summary, the immune system can recognize and kill cancer cells. We know that now, but we know that tumors evade that through different techniques and have evolved to sort of block that immune response. So we use newer immunotherapies to unlock the body's immune system to fight cancer, and this strategy has a number of advantages. I list 2 important ones here. One is the immune system is very specific. So once you unlock this, it actually recognizes that tumor cell very specifically, meaning it's less likely to cause side effects on normal cells, whereas things like chemotherapy really affect cancer cells and also normal cells. And so that's one of the downsides of other non-immune therapies. But immune therapies are very precise and they target the tumor. And also that even after you stop treating with some of these immune checkpoint blockers, for instance, the responses can often be long-lived, because once you trigger that immune response, it's really your body that is the drug, and it's not so much the drug itself. The drug is just unlocking your own body's immune response. So, but these newer strategies are very exciting, but obviously we've got a lot of work to do, and a lot of patients are still not responding. And so we have new strategies that are in development and likely coming in the next few years. Some already are here, CAR T cells being one of them, but then also some of these molecules that directly activate the immune system in tumors and allow more patients to respond. So I want to thank you for your time, and happy to take questions at the time when it's available.
Thank you, Dr. Swice. Up next, we have Dr. Chowdhury, who is an assistant professor in the Department of Medicine, section of genetic medicine from the University of Chicago. Her interests center around understanding how human adaptive immune pathways operate to maintain tissue homeostasis, and how dysregulation of these processes lead to inflammation and to cancer. So please welcome Dr. Chowdhury.
All right. Good afternoon, everyone. And it's an absolute pleasure to share our vision or have this opportunity to really share an immunologist's perspective of appendix cancers with you today. When I started researching appendix cancer, I realized that there is limited, although a growing body of information available on the incidence rates, the different types of appendix cancers, the symptoms, which unfortunately many of you have personally experienced, and of course the tools that we now have to diagnose and treat appendix cancers. However, one thing that is almost always conspicuously absent is the cause. Now, if we want to develop preventive strategies or find a cure, it is absolutely important for us to understand why and how appendix cancers develop. And therefore, our aim is really a very simple one. We want to identify the factors that drive the development and progression of appendix cancers. In order to do that, I believe that we first need to shed the old concept that the appendix is a vestigial organ. Now, like many other organs in your body, including the tonsils, spleen, the lymph nodes, the appendix is actually a secondary lymphoid tissue or an immune organ. See, it's important to understand how an organ functions in the healthy or normal state and how those functions get dysregulated in the context of disease if we want to identify ways of restoring the normal functions and regaining health. Therefore, we must start by recognizing that the appendix is an immune organ. The other important function of the appendix is that it is thought to be a reservoir of beneficial bacteria, which actually helps to maintain the health of your gut. Unfortunately, however, these two functions of the appendix have been for a really long time overlooked because the appendix is thought to be a mere extension of the colon. But if you were to take a cross-section of the appendiceal tissue and a cross-section of the colon, this and observe it under the microscope, this is what you would observe. And clearly, the two images do not look alike. In the appendix, you have a bunch of these circular structures that you see here, which we call lymphatic nodules. These are actually the sites where you have a bunch of your B cells that make antibodies. They actually reside there. A lot of your B cell, T cell interactions happen at these sites. As you can see that these are very rarely found. These blue ones here are actually the lymphatic nodules in the colon, but they're very scattered and isolated along the length of the colon. So what we do know is that the appendix is clearly distinct from the rest of the intestine. What we do not know, however, is all the different types of immune cells, all the different types of T cells, B cells, what their normal functions are in the appendix, what their characteristics are, what their behaviors look like. All of that remains unknown. So our objective is truly to kind of break open this black box, understand what the appendix is doing as an immune organ to maintain your overall health when in healthy people, and how those functions are perturbed in appendix cancers. One thing that we do know is that the immune architecture of the appendix changes as you grow older. As you can see here from this study, the number of lymphoid follicles, or these circular structures that I was just talking about, gradually decreases as you grow older. And this can have significant consequences because, as many of the previous speakers have highlighted, age is truly the only major known risk factor for appendix cancer. So the question that we are interested in asking is, how do the fact that these lymphoid follicles decrease or their functions change as you grow older affect the development of appendix cancer? The other important question that we're trying to address is, does age truly have an effect on how your appendiceal microbiome change, Or do these changes in appendiceal microbiome as you age play a role in driving the development of appendix cancer? In the context of the immune response, it is critical to understand the immune architecture and the function of the appendix. And that's because, as I mentioned, you have a lot of T cells and B cells that are present in the appendix because it's an immune organ. But T cells, as has been highlighted in the previous talk, are critical in your defense against tumor. T cells can identify specific antigens that are expressed by the tumor cell, and they can actually selectively target and kill the tumor cell. Under certain circumstances, the T cells can also express these proteins called checkpoints that can, essentially just prevent the killing from happening. But thanks to science, we now have checkpoint blockade therapy, which can actually reactivate or re-stimulate the T cells to induce tumor cell killing. The real question, however, is can immunotherapy work for appendix cancers? The answer is yes, if there are T cells infiltrating in the tumor. In the context of appendix cancer, very rarely do you find T cells and B cells actively infiltrated in the tumor. And most of the metastatic cancers that you find in the context of appendiceal diseases, there aren't very many B cells or T cells. And that's why these tumors can be classified as cold tumors. And if you have no T cells and B cells infiltrating in the tumor, you cannot really use immunotherapeutic approaches. But you can develop alternative strategies. And one of the questions that we must ask ourselves is why is it that the B cells and the T cells are not infiltrating in the tumor if the appendix is an immune organ and you have a ton of these cells present there? One possible answer is, as has been shown in other cancer contexts, is that there are other immune cells in the tumor microenvironment that actually suppress the infiltration of these cells. For example, there are certain cells that can express proteins or cytokines like TGF-beta. If that were true for appendix cancer, then we could develop alternative strategies like injecting TGF-beta blockade strategies, and thereby re-stimulating or reinvigorating the tumor microenvironment and inducing the infiltration of T cells to perform their natural functions and induce tumor cell killing. The other approach is if there are other cell types in addition to T cells that are called natural killer cells or NK cells, which could be present in the tumor microenvironment. And we now have strategies to actually activate these cells to induce tumor cell killing. So the bottom line truly is that we know so little about the tumor microenvironment in appendix cancers, and all the therapies have been mere extensions of what we have learned from other immune microenvironments for other cancers. So we must begin by truly asking, what is the tumor microenvironment in appendix cancers like? This is also important because we can, if we understand that, we can actually develop specific or targeted therapies for appendix cancer. And I say that because as I mentioned, and other speakers, that the T cell can actually recognize specific antigens that are expressed on the cancer cell and kill it. As you can see here in this video, these are T cells that are actually identifying a cancer cell and then actively inducing the killing of that cell. But there are other cells in the tumor microenvironment, like you can see this cell here, which is kind of not really participating in that process. And that is because not all the T cells in the tumor microenvironment are specific for the tumor. You can have T cells in your body or in that environment that are specific for viruses or bacteria or other pathogens or even commensals. But one way of understanding which T cells are actually responding to the tumor is by sequencing your T cells, which is now routinely performed, and we do that all the time. And we do that because the T cells that are thought to respond to the cancer will traditionally or expectedly proliferate because they have to tackle the challenge. So they make multiple copies of themselves by a process called clonal expansion. So in this case, for example, this green T cell has multiplied by clonal expansion. And if we were to sequence a patient's T cells, we could actually identify which T cells have actually proliferated. The questions that we then ask is, by identifying these T cells, we can ask, what are these T cells responding to? For example, in this case, this circular antigen or protein or a cell surface molecule or something that the cancer is uniquely expressing is being identified by the T cell to kill that cancer. Now, if we identify what this protein is or what this molecule is, we can develop targeted therapies like CAR T cell therapies. We can also ask, what are the characteristics of these T cells that are actually successfully killing the tumor? And once we identify those factors that are uniquely kind of helping these T cells to kill the tumor, can we then develop therapies around it? So these are some of the questions that we are trying to address. And we are using a suite of cutting edge methods to actually address some of these questions. And we've published in top tier journals before in the context of actually infectious diseases, cardiovascular disease, and allergies actually. We're now trying to use these approaches to truly profile the appendix tumor microenvironment, understand what the immune microenvironment in the appendix looks like, how they behave, to the goal precisely being to design preventives and truly targeted tissue-specific therapies. In order to achieve these goals, we've actually partnered with an excellent team of experts. Dr. Kiran Turaga, of course, who's an exceptional surgical oncologist. We have Dr. Mark Bissonnette, who has expertise in colorectal cancer. Lindsay Alpert is our pathology partner. And of course, my lab and a fellow from Dr. Turaga's lab, where we've developed this interdisciplinary team because we truly believe that appendix cancer is a multidisciplinary problem, and we need an interdisciplinary team to tackle this. We believe that with this, the expertise of this team, we can truly create a new frontier in our understanding of appendiceal immunology, and we can truly transform the way in which we think about monitoring, diagnosing, treating appendix cancers, but also start thinking about prevention, because by finding the cause, we can actually prevent. I would like to thank, of course, ACPMP, the foundation, for giving me this opportunity to share my mission and my vision with all of you today. And I hope that you will all join and help us and support us in this cause and effort. Thank you very much, everyone.
Thank you so much, Dr. Chowdhury, for coming on and talking with us today. Up next, we have Dr. Levine, welcoming him back to give an overview about the BROMAC trial. And then following, I want to reiterate that there was a brief change in the scheduling, that Dr. Harmath will come on after Dr. Levine to talk about imaging. So please welcome back Dr. Levine.
Hello again, everybody. I'm here to talk to you about something a little bit different than the morning talk, which was sort of a general overview. And I think we're going to be dealing with a system which is, I hope, somewhat more simple to understand, which is a specific study, which I'm asked about very frequently. And what I'm talking about specifically is the status of the bromelain trial, sometimes called the BROMAC trial. And I hope you can see my screen at this point. Thank you. So the first question is, what is bromelain anyway? And bromelain, I'll show you some different spellings. And interestingly, if it's spelled differently in United States, England, and Australia, but I think either one of those spellings are, I think, acceptable according to the dictionary. Bromelain is actually a group of enzymes which come from pineapples, from the fruit and the stem of pineapples. It's available as a nutritional supplement. And what you see below is a number of absolutely positively not recommended nutritional supplements. Those do absolutely nothing for PMP as far as I know. That's when this medicine, when this enzyme is given orally. So although people will try to sell you this, this is not something that's likely to help you, what we've got here. So bromelain actually dissolves mucus. And if you're a chemist or a biochemist, there's specific enzymes, cysteine protease hydrolase, it lyses glycoproteins or divides glycoproteins, and are found in mucus and mucin, and that's one of the things that holds them together, chemically speaking. It's given with, in this trial, N-acetylcysteine, which is a common mucolytic agent which we use for people having breathing trouble with a lot of mucus in the airway. So this is given both together, bromelain with N-acetylcysteine, and together they were combined and is called Bromac. So that's what this Bromac trial is about. Now, we all know that we've been hearing about mucin being deposited in the abdomen for mucinous ascites. The problem with the mucin in the abdomen, when you find it with pseudomyxoma, is it is usually so thick and viscous it cannot be removed with a needle. It's a lot like putting a straw into a jar of grape jelly and trying to remove it. It's just too thick and viscous, it won't come. So there's been some work done using these mucolytic agents to be injected, again, not taken by mouth. This is injected directly into the pseudomyxoma via a needle or a catheter, and injecting this enzyme with the N-acetylcysteine to try and let the mucin become liquid so it can be evacuated through a small catheter or a needle. This has been pioneered, and this study is being led by Dr. David Morris in Australia. This agent is currently not available in the USA, not available in Europe. It's available on protocol in Australia. Unfortunately, due to the COVID pandemic, you can't really get to Australia. And that is shut down because I've referred patients over there to get it when we couldn't get it here. There is a phase 1 trial which has been completed in Australia, and there's a small phase 1 study of this which is currently open and accruing in Spain as a single place. What did these studies show? And I put some asterisks after the not available in the USA. They're available actually if you can get the material or the bromelain from Australia, and I've been kind enough to receive a supply from Dr. Morris, and you get approval from the Food and Drug Administration for an emergency investigational drug application, and you get approval from your local institutional review board or research agency, then you can potentially treat someone with this under extremely controlled, extremely limited case-by-case situations. Going through the hoops to get that done is extremely time intensive, not something you can hand off to a secretary to do. And the last time I tried, it took about 2 months to get done. So the phase 1 trial was completed in Australia. What they did was they used a catheter and placed the catheter into a mucinous collection of pseudomyxoma. They tried to collect and aspirate what they could. Obviously, they didn't get very much out at that time. So they then injected bromelain and N-acetylcysteine, or Bromac, and the doses you can see there. And the patients then went home and came back about 24 hours later for aspiration of what was then partially liquefied bromelain, or partially liquefied pseudomyxoma. They could redose at the choice of the investigator and follow up again 24 hours later for additional aspiration. This is what it actually looks like. This is a patient I treated with emergency FDA approval. There's a catheter. In this case, it was in his chest. And we're injecting the material. We let it sit. And what you see coming out, the purplish stuff in the container, that is mucin pseudomyxoma, which has been lysed. So that's basically how it works. This trial, we've been trying to open for some time. And unfortunately, as far as I can tell, the American Food and Drug Administration and the Australian version do not like each other because they don't communicate very well. And it's been very tough to get this through. Our FDA has demanded a number of things to be changed over time. And to tell you how granular this has become, it turns out that bromelain is actually a family of enzymes, not a single enzyme. And the concentration of them has to be accurately determined if you're going to use it as a drug. The FDA wants to know what those concentrations are. And that's going to depend on what type of pineapple you get, because there's different subtypes, and where in the ripening cycle you get it. So this turns out to be pretty complicated to get this done right and get it manufactured. The study, which is currently planned, and again, there's several sites, and I'll show you what they are in just a minute, is going to be looking at, the goal is to look at what the ORR's overall response rate to treatment using the BROMAC, looking at CAT scans before and after administrating the material. Now, this is part of a research trial. This is not for general use at this time. For it to be approved, it's going to have to pass trials such as this one. Secondary objectives are there any adverse events? How long does it take for whatever you remove to reaccumulate? Pre and post assessments of symptoms and quality of life scores. The inclusion criteria are going to be, you have to have appendiceal origin pseudomyxoma peritonei, which is otherwise unresectable. So if you can have conventional surgery, this BROMAC trial is not going to be for you. And again, this is given a standard dose. The only real exclusion criteria, if you have the appropriate pseudomyxoma, is an allergy to bromelain or N-acetylcysteine. How you would know you had those allergies before you start, I don't know. So you're not going to know that you're allergic to it until you get the drug. This is a list of the current sites which are either available or are scheduled to be available or are hoping to become available. So yeah, there's one in the Netherlands. They've got a few in the United States. I'm very proud for us to be one of them. There's one in France, one in New South Wales, which is the headquarters site. That's where Dr. Morris is in Australia. And there's one in Spain, which is tentative, and they're doing the other side doing the phase 1 study. I think they've treated a total of 6 patients there so far. So I've been in touch with the people in Australia for some time, and what have we learned? The current status. Apparently, the FDA has listed what they want. There are plans for a production run for the second week of November to make drug, and now the drug has to be combined in a single vial. We used to use the bromelain and N-acetylcysteine and mix them at the patient's bedside. The FDA has demanded that they both be in the same vial, so you can treat them patients at the same time, which they view as a safety issue. That's supposed to be produced second week of November. It then has to go through a number of quality checks. And if that works, then we'll hopefully be able to get these drugs out. We then will have to get official research approval at the various sites. So the hope is to have this trial open to accrual early in 2022. I would guesstimate February, potentially earlier than that. However, this study has run into a number of snags along the way. I was hoping to have this trial open here in the US, as was Dr. Morris, more than a year ago. So we've been struggling to get this study open, and hopefully we'll be able to enroll patients. The best patients for this are patients who have got large pools of mucin that are able to be drained by putting a catheter into a single or no more than 2 sites, and are otherwise healthy enough to undergo these procedures. So this is not for everyone. And unfortunately, this is not a curative treatment. This is a palliative treatment to help patients who are having particular problems who are no longer candidates for surgery. If you are interested in getting on a waiting list, you can certainly contact any of the sites before, and we can put your names on waiting lists. This is a study which is going to be running for a limited period of time, even after it opens. So if you think you're a candidate, certainly get in touch with one of the centers. And that's the current status of the BROMAC trial. I'm hoping to get this open. There's been a great deal of interest in this, and I've got a lot of patients who are interested in it, and I know there are others, frankly, around the world who are going to be candidates. And I salute the team from Australia, Dr. Morris and his team, for keeping their shoulder down and pushing the boulder forward so we can get this study open to help all the patients who could benefit from it. Thank you.
Thank you, Dr. Levine, for that update. I know our patient community was excited to hear some feedback about this exciting trial. Up next, we have Dr. Harmath from the University of Chicago. She's an associate professor of radiology at U Chicago and chief of the section of abdominal imaging. Her research interests include oncologic imaging, transplant imaging, and novel imaging technologies. One of her main professional goals is collaborative approach to teaching and patient care with full engagement of the professional team and patient. She's going to be talking about best imaging modality for appendix cancer. She's going to be coming on, and then shortly after, we will begin the nutrition and QOL roundtable around 1:50. So please stay tuned for that. And I'm going to open up for Dr. Harmath. Thanks.
All right. Hi, good morning, everyone. Welcome. I was asked to discuss the best imaging modalities for appendiceal cancer, being CT, MR, or PET. So let's go through it quickly. We have just to remember that there are different types of neoplasm that involve the appendix, and we generally distribute it or classify it into mucinous and non-mucinous tumors for our diagnosis and for the workup. Most appendiceal neoplasms like to spread in the peritoneal cavity, and that can be challenging for us as radiologists and imagers. The peritoneum is this thin membrane that surrounds every organ and lines the interior wall of the abdominal cavity, and is less than 1 millimeter thick, so it can be very challenging to visualize it in imaging. So just a few examples on how metastatic appendiceal cancer can look. On the left-hand side here, we have a mucinous tumor, which basically looks like fluid containing lesions around the organs, and they're delineated by those arrowheads. On the right-hand side, we have more solid-looking tumors also pointed with the arrowheads, and those have more of what we call a soft tissue characteristic, meaning they're not fluid-looking. They look more like cells and the other tissues in organs or muscles, for example, that we can see surrounding the body wall. So those have different ways that they look like in imaging and different ways that they react. And that can be challenging to image because the mucinous tumors usually are not going to have what we call enhancement or activity on PET unless they have a solid component. The solid tumors, on the other hand, they will show what we call enhancement after contrast, and they will have usually some activity on the PET exam. So what exam is best? It's going to depend on the patient, and it's going to depend on the type of tumor. This is an MRI showing how tumors can look like, and this is a tumor that has more solid components. And on the MRI, these areas pointed out by the arrowheads are actually the solid components of a tumor. There are several different what we call sequences in MRI, and that's why patients do spend a larger amount of time in an MRI scanner than a CT scanner, because we're acquiring different ways that things look. For example, this one that I'm showing now is what we call a T1 image, and that is an image that we use after contrast and pre-contrast to look at the solid components that are enhancing. Now, this other image that I'm showing is what we call a T2 image, and that is sensitive to fluid or fluid-like structures. So this is showing here an appendix that is abnormal with fluid, but also shows a little bit of the bladder with fluid and some small bowel loops with fluid. So with MR, we need these different sequences to show and characterize a lesion, whereas with CT, it's mostly contrast or non-contrast. There are not that many different sequences or phases. Moving on to a PET exam. So a PET exam is an exam that does involve radiation, but we use glucose that is bound with a radiopharmaceutical in order to see that activity. So solid tumors are cells that are multiplying, for example, they need a lot of glucose. So they're going to uptake this glucose that is bound to the radiopharmaceutical, and then they're going to show activity like we see here on this exam. So this is the CT part that goes with the PET exam. The PET exam shows this brighter areas, bright orange or yellow here. These are the tumors that are active, depicted here by just these areas that are not very well defined on the CT exam. So you can see that different exams have different appearance, and different tumors have different characteristics that are better seen in one or another imaging modality. Also, just to take into consideration, our own body habit is really is a little bit tricky, because some people that have more intra-abdominal fat make these structures a little bit more contrasty on a CT exam. So I have bowel here, and then I have the peritoneal fat. That really makes it easier for me to see this abnormality here involving the cecum, where the appendix is. However, in a patient that has less intra-abdominal fat, everything overlaps a little bit. You see the muscles closer. There's less of that fat that promotes that contrast, and it can be a little bit harder to see subtle tumors, especially along the bowel wall. So let's go briefly over every modality and talk about a little bit of the pros and cons. So this is contrasting hand CT. The pros is that, it does have a superior spatial resolution, meaning, the little structures close to each other can be well depicted. It's fast. We can be in and out in like 5 minutes. It's readily available. So a lot of places have it, and most places are very consistent in terms of the quality. So it's very reproducible. So whatever you get a CT imaging, most of places are going to have the similar quality. The cons is that the sensitivity is about 11% for lesions less than 5 millimeters, but still they can be seen. And it can be very difficult to distinguish a thin tumor sheet, especially in the peritoneum, from normal peritoneal lining. Sometimes the peritoneum gets thickened by other things like inflammation or even postoperative changes and fibrosis, and that makes it very difficult in any imaging modality to distinguish tumor from the normal structure. A PET FDG, which is the one with glucose, it does localize malignant tissue by increased tracer uptake. However, anything that is acting fast or reproducing or replicating fast, like cells that are active, may show activity. So we have to know which areas are normally showing activity versus which areas are going to be tumor. The cons is that small volumes or thin tumors may not create enough activity for us to be able to see them with a PET. If it's not a solid metastasis, like in the cases of mucinous tumors, for example, mucin is not going to produce enough activity because the cells that are producing mucin are the ones that are active, and sometimes they're very small. They produce a lot of mucin, which is that gelatinous fluid looking like structure, but they are not active on the PET. So that can be tricky to image with FDG PET. Again, if not a solid metastasis, it may not have enough activity, and certain tumors themselves do not produce or replicate very fast to promote enough activity for us to see on PET. And lastly, MRI. This is a specific sequence that we call diffusion weighted sequence, which is basically a sequence that is sensitive to the motion of fluid within a lesion. And it takes into consideration that most tumors are very packed in cells, very tightly packed, so they don't let the fluid move around. And this will restrict the diffusion of fluid. So this is how these would look like on diffusion weighted imaging MRI. So it does have a high per patient sensitivity because the tumors will look generally bright, but per lesion sensitivity is about 20% because it's very difficult to distinguish some motion artifact and fluid in bowel sometimes from these areas of activity. Lesions that are less than 3 to 5 millimeters will be very difficult to see, especially if they're adjacent to bowel or fat or air-containing structures. The peristalsis, which is the bowel movement and bowel gas, will promote artifact on MRI, which can limit the visualization. And again, mucinous tumors are going to be fluid-looking, so they will not really restrict the diffusion of fluid, and they can look just like fluid. So that may be difficult to distinguish from, just routine fluid or postoperative fluid on MRI. So just for the future, we're working together with our team here at University of Chicago, and we are trying to get better ways of imaging peritoneal tumor in general. And with the help of our patients, we've been developing higher resolution MR imaging, trying to outline the wall of the bowel, the exterior wall, which in this case, for example, is very thick in the peritoneal lining and the wall of the bowel in the surface where the peritoneal lining is covering it. And we're developing the sequence to try and distinguish very early tumor involvement in the peritoneum. And this is, the intraoperative appearance that the surgeon saw after we saw this peritoneal lining thickening. Similarly, here we have this very subtle areas that are, demonstrating the peritoneal lining thickening. And when the surgeon went in, that's what they see in terms of the tumor presence. So just some take-home points. Different types of tumor may benefit from different imaging modalities. So it all depends on what type of tumor you have. And also different patients may benefit from different modalities. It all depends on our body habitus and how the tumor is presenting. Even the same patient at different points in time may benefit from different modalities of imaging of the tumor. So it's not a one size fits all, and we have to really try and personalize medicine to all of our patients. So discussing it with the surgeon, discussing it with the radiologist, and having a team approach to the imaging of appendiceal cancer is the key. And I appreciate your presence and participation. I'll be free to answer questions later on this session today. Thank you.
Thank you so much, Dr. Hermoth. Up next, we have the Nutrition and QOL Roundtable, which will be an open Q&A with a couple of panelists. We're welcoming back Dr. Lambert from the Huntsman Cancer Institute, who is the Professor of Surgery and Director of the Peritoneal Malignancy Program. We also will be having Deborah Shelton on as a moderator, and she's the Executive Director with the Appendix Cancer PMP Research Foundation. We're also welcoming Jeffrey Wetridge, who is the Clinical Dietitian in the Regional Therapies Surgical Oncology section at the University of Chicago. We also have on Monica Moorfield, who's an inpatient registered dietitian who's worked with HI PEC patients for over 10 years at the Wake Forest Baptist Cancer Center, and Dr. Katie Duckworth, who is the Assistant Professor and Interim Director of the Psychosocial Oncology Program at Wake Forest. And we also will be having Emily Prieb from Huntsman joining us too to help answer. So please welcome our panelists and our moderators. I want to reiterate that this session will go until 2:10, and then we'll open up to the open forum. Thank you so much.
Thanks, Lauren. Emily is actually on the participants list. Can somebody let her into the session? Thanks. Sorry, go ahead, Deborah.
Okay, great. Well, thanks very much to all of the people, all of our healthcare professionals and other panelists presenting in this. It's really my pleasure to co-moderate the Q&A sessions with Dr. Lambert. We do have quite a few questions, so let me just say at the outset, if we're not able to get to your question, please do reach out to us by writing to us at info@acpmp.org, and we'll do our level best to get you answers. But we do, for the nutrition quality of life, we've gotten several questions about nutrition and diet. And so let's maybe Dr. Lambert, we could open with that. Dr. Levine, I believe, spoke to us earlier today, among others, about the role of diet in appendix cancer and in managing the disease. But we've gotten an interesting question or two about how does one balance kind of the advice to eat lots of fruits and vegetables with the medical clinical need for a low fiber, low residue diet following surgery, following bowel resection. Anyone want to take that up?
Sure, I can touch base with that. Generally after the procedure, it is kind of often recommended to take a low fiber diet. I do know that we're always transitioning our patients as quickly as possible back to kind of a healthful diet or a healthy diet that does include more whole grains and fruits and vegetables. Usually in our pathway, we'll see patients about certainly the next week after surgery, and then I'll be following them for that 6 weeks to the post-op visit. And so in that time frame, we're working on appetite, early satiety, and making sure that we're maintaining weight. And certainly in that time period, we're working towards increasing the fiber.
Right. The fiber restriction is temporary. Sorry.
No, go ahead. Sorry.
I was just saying, to reiterate, the fiber restriction is just temporary, just for a few weeks or so.
And could one of you speak to fiber itself? So obviously it plays, I think it's very confusing for people because sometimes it's used as a laxative, sometimes it's used as a bulking agent. There are different types of fiber. And so this question comes up pretty frequently. Can one of you, Monica or Emily, maybe just expound a little bit on how you think about fiber and in what settings and how you recommend using it?
Yeah, I mean, for me, obviously depending on their bowel issues, I always kind of talk about there's a couple different types of fiber. The insoluble fiber is going to have a little bit more of that laxative effect and get things moving. So if you are experiencing diarrhea or something, that's not as much what you want. Whereas you have that soluble fiber, which I feel like can be helpful with diarrhea, coming from applesauce, bananas, white rice, those types of things, but can also block things up too if you do a little too much of that.
So just if I could, that's really interesting. And I'm sure that just in conversations that I have with patients and caregivers, that they will be very interested to kind of understand that the fiber restriction is generally temporary. I know that we, often see things from patients about their concern with small bowel obstruction. And so it seems like long after their surgery, they're still really limiting themselves and staying on a very low fiber diet. So that we can all understand, is that perhaps something that may not be necessary? Is that what I understand?
I think it could be. Go ahead, Monica.
So that is a tough question, partly because if a patient has had a bowel obstruction, that changes things just a little bit. So we would be a little bit more cautious in that fiber restriction. But if a patient has not had sort of the bowel obstruction, we would certainly kind of liberalize the fiber. So I think that was sort of two questions in one. But patients do have a tendency to kind of self-restrict, but we also try to encourage them to get back to a regular diet.
Excellent.
Right.
Excellent. Oh, please go ahead.
Oh, I was just agreeing. And the focus is, with the bowel obstructions is really the insoluble fibers, the skins and the nuts and the seeds, and consistency can also play a big part of it. So the softer, closer getting to liquid diet may be necessary for some people.
And Deb, there's kind of a good follow-up question to this topic in the live questions. And this person is asking if somebody after the HI PEC surgery is still having trouble digesting fruits and vegetables, whether cooked or raw, do you guys have any recommendations for how to get the important nutrients that we hope people will get from these types of foods?
So you could try blending them up into smoothies. That sort of thing might be tolerated better than especially if it's a bowel obstruction related, partial bowel obstruction related.
Good. And then we have some psychosocial questions too, but trying to consolidate some of the nutrition questions. Anything additional that any of our experts here would add or suggest for patients that have long-term gastro issues? And specifically, we got some questions about, because of the gastrointestinal issues, we have a hard time storing nutrients and therefore we suffer from chronic fatigue. Any suggestions there to maybe help mitigate some of that?
It is specialized to, the specific surgery that they had. So really needs to be focused on, just individualized. It's hard to give broad guidance since it is individualized.
Right.
I would sort of have to agree with that too, in terms of finding out what the patient really is able to tolerate, and kind of working with that patient to be able to customize it a little bit more to get more variety.
Can any of you speak specifically to vitamin B? A lot of these patients, because they have cancer of the appendix, have had a right hemicolectomy. And do you guys have recommendations for replacing vitamin B in that setting?
The recommendation is really just to replete if low. It's not to automatically put them on like B12. So yeah.
And I think that's definitely, we would always be monitoring for B12 status. And we actually recently had a patient when we did a workup for a B6 or paradoxal deficiency as well. So that was new to see. And I know that just carrying on, we're also trying to be watching vitamin D level as well.
And then I guess, Dr. Lambert, following up on that, so we've talked a little bit about diet, nutrition, a little bit about supplements, vitamins. How about exercise? We get a lot of questions about that. Like, are there any kind of secrets, if you will, suggestions, tips that might help keep people healthy, long-term survival strategies from an exercise standpoint? Besides do it, I would imagine.
I always just say, get moving however you can, and also thinking about ability too, but just getting the heart rate up a little bit, going for a walk, getting moving kind of helps get the gut moving, things like that. And just finding something you enjoy so it doesn't feel forced.
Any live, Dr. Lambert, or anything you want to chime in on?
Yeah, I mean, I can speak, to this as the surgeon who's seeing people who are going through this type of surgery. I tell people before surgery that the HI PEC is kind of like running a marathon, and the best training that you can do for it is aerobic exercise prior to the surgery. And the more fit a person is coming into it, in my experience, and I think most people would agree, they tend to do better after the surgery as well. So I tell people if they don't smoke, don't start right before the surgery. And, if they do any kind of aerobic exercise, walking or swimming or biking or hiking or whatever, keep doing that. And you will find that after the surgery, it'll be so much easier to get going. It'll help your gut health. It'll help your just your psychological and emotional health, just to be able to get up and moving. And I'm sure that at all three institutions, we all insist that the patients get out of bed either the same day or the next day at the latest, and they're working with PT, and we have them ambulating in the hallway. And I know here half the time our ICU has our patients walk to the floor when they transfer, which is always amazing to me. So yeah, so moving is really the best thing you can do.
Great, good. And I'm just going to keep checking my time here. And so we still have about 9 minutes. So that's great. Let's shift gears if we can to some of the psychosocial kind of questions, concerns, and maybe Dr. Duckworth, this is best for you. I don't know, but welcome all feedback and input. But in terms of fear and anxiety that comes with any cancer diagnosis, managing that, that fear, that anxiety, where it can really become quite paralyzing. And, that's with a diagnosis. And then also we see the same types of issues where people go through treatment, no evidence of disease, but forever haunted by the fear of a recurrence, to where it's really disruptive to everyday life. What are your thoughts about that? Any suggestions, kind of tools that maybe you could offer patients?
Sure, absolutely, Deborah. You're right that I think fear of recurrence is pretty high, understandably, within this population. And so along the lines of the former conversation here, one strategy is to focus on the controllables. So all of those things, those opportunities for meaning and pleasure and structure in our lives that we can have some control over, that's a really good thing to lean into. So exercise and, again, just really meaningful activities that we can structure into our day and what we can impose is a big piece of that. I think another piece is acknowledgement and sometimes giving words to those strong emotions that as human beings we tend to avoid or try to compartmentalize. Really be helpful in terms of managing some of those intrusive thoughts. And we've done a lot of really great work here in examining sleep quality and sleep disturbance. And so we know that oftentimes those fears that we harbor and those intrusive thoughts visit us in the still of the night when other things aren't there to vie for our attention. And so focusing a lot on sleep quality and sleep hygiene, and again, exploring some of these things that we oftentimes shield our loved ones from with maybe a professional or someone with whom we can confide, a close friend, is really helpful. And so other healthy activities like exercise and, again, structuring meaningful activities throughout the day can really be helpful in that regard.
Great. And I would think, but tell me if there's a different set of considerations for caregivers and family members of patients, like just, on a personal note, I'm a long-term cancer survivor, different cancer, but now I'm the caregiver and spouse of an appendix cancer patient. So my mind, I must say, and I'm sure I'm like many others, goes constantly, is it the same set of kind of tools that you would recommend for caregivers that are anxious about their spouse's recurrence or whatnot?
Great question. I think there's a lot of overlap, but what's really important to underscore here is that we are really working to put caregivers on the map from both a research and a clinical perspective, because we recognize that they oftentimes have very different quality of life trajectories, and the concerns they have can be very different. And so they, in their own right, warrant and deserve a lot of research and attention. And so in some of the preliminary studies that we've done here, we have found that the trajectories that we see and depressive symptom burdens and quality of life symptom burdens are actually quite different and move at different time points compared to patients. So oftentimes that pre-intervention time point is really hardest on our caregivers. And then the post-surgical time point is harder on the patients, given the physical symptom loadings that they're experiencing. And so I think just recognizing that there are differential trajectories, different time points where patients and caregivers might be struggling more, comparatively speaking, is really important. And then recognizing just the strain a lot of our informal caregivers experience is quite different, and that just the social restrictions and the need to balance really heavy caregiving responsibilities in tandem with other life roles can really take its toll over time. And yet there's a bit of a social stigma, I think, for our caregivers reaching out and saying, I need some help here, I need to talk with someone. And so I think just relieving themselves of that self-imposed burden, or the burden that society sometimes puts on them, just to carry it valiantly without complaining, if you will, is really key. And so again, I think putting their needs on the map, acknowledging that they need to be assessed and have an equal number of services available to them is really instrumental in this point, and just continuing to make those same resources available to them that we do to our patient populations.
Great, thank you. Dr. Lambert, do you have questions, input?
Yeah, so I hope it's okay. Thank you, Dr. Duckworth. This aspect of what people go through just from the cancer standpoint, and then the major surgery, being in a rare tumor, or having a rare tumor, that space, all the unknowns is, I think, exceptionally challenging, for people and their families when they're dealing with appendiceal cancer and pseudomyxoma. And so these efforts that you're doing to look at both the caregiver and sleep and all these aspects are hugely important to the success of any treatment that we may offer. One question that I don't want to necessarily go back to the nutrition, but there is an important question that keeps coming up, and that's the sugar question. So I know Dr. Turaga did make kind of a statement about that in his talk, but I'm going to throw it back to the dietitians here, because we get asked this all the time. What do you get? How do you counsel people about sugar? People are asking if they should avoid all sugar to try to prevent a recurrence. How do you counsel people about that? And Dr. Duckworth, I think this does have an impact on quality of life, because I love sugar.
For sure, I agree.
Emily or Monica?
So limiting added sugars for sure, and but overall, like, carbohydrates are still healthy, and just want to focus on whole grains, not refined white flour, that sort of thing. So it's still healthy because all your healthy cells use the, carbohydrates break down to glucose, and your body uses that to function for energy. So you don't want that cut down. But
I'll always kind of talk about the importance of maintaining weight, staying strong for treatment and for surgery and everything. And sometimes depending on side effects, the diet's already kind of limited. So then to kind of restrict an entire food group just for the fear of the glucose, just feel like can be kind of problematic. So I'll usually discuss that in more detail.
And I just try to kind of, reemphasize that, whole foods are real foods wherever possible, and, kind of work towards either a low glycemic or anti-inflammatory based eating where, you can control what you can control, and then kind of work towards always improving your eating strategies and what you're doing on a consistent basis.
Yep. All right, I think if I can just make one final comment. So, our bodies require a certain amount of sugar. Our brain and our heart preferentially use sugar as their source of energy. And if you starve your body of sugar, it's going to get it from other sources. So like Emily was saying, it's going to break down muscle mass to produce sugar to maintain the homeostasis that you need. So all things in moderation. And this really isn't the time to be depriving yourself of every last little bit of joy in your life, right, Dr. Duckworth?
Correct. I concur wholeheartedly.
All right. I think, Deb, we need to move on to the next session, but I want to thank all of our panelists. I apologize for it being short. I think I'm the culprit of that for running over in my talk. But thank you all for joining us. And
thank you.
If anybody has any additional questions on this topic, bring them up in your regional symposiums, because we'll have representatives from this group at each session. So thank you.
Thank you.
Thank you everyone so much for taking the time out of your day to join us this afternoon. And as Dr. Lambert said, we have so many questions come in. I hope that we could answer a good majority of them. But if you didn't get your question answered, definitely take some time during the regional sessions from 3 to 4 o'clock to ask those questions. So up next, we have the open forum, Ask the Experts. We're going to be having the same moderators, Dr. Lambert and Deborah Shelton with ACPMP. And we're going to be welcoming back Dr. Levine with Wake Forest, Dr. Turaga and Dr. Eng with the University of Chicago. I want to do a brief introduction of Dr. Eng. For those of you who don't know him, Dr. Eng is a double board certified surgical oncologist who focuses on the treatment of cancers in the abdomen and in particular cancers that have spread to the peritoneum. He specializes in CRS HI PEC and treats a variety of abdominal cancers and is skilled at minimally invasive approaches. So please submit your questions via Q&A and we'll try to get to as many as possible. Thank you.
Okay, well, great. Thank you. Thank you, panelists. So let's see. So the way that we did this, I think Dr. Lambert and I have split up the pre-submits, the questions we got before registration, and then what's coming through live. Dr. Lambert is doing the yeoman's work of monitoring and culling through what's been coming live. But I can say between the two sets of questions, I think we're up to probably over 75 questions. So let's try to kind of do rapid fire as best we can. I think we're both working to collapse questions. I will say some of the questions that we've received have been addressed now through some of the presentations. We realize that's a lot to go back through the presentations, but again, if you don't get your question answered, we'll try again at the regional. If that doesn't work, please feel free to contact the Research Foundation at info@acpmp.org. We will do our level best to get you answers. So let's just start right off. Let's go back to kind of treatment, the treatment bucket, if you will. Got tons and tons of questions about HI PEC specifically, and trying to collapse a couple of those questions. One, patients have a lot of concerns about potential long-term adverse consequences of HI PEC. Dr. Levine, I believe you touched on one, depression, but we also often hear concerns about, are there possible neurological effects? Are there possible cardiovascular effects? So how do we think about that? How do you all think about that? And then does the answer depend? I'm a lawyer by training, so my answer is often, it depends. Maybe that's your answer, but does your answer about long-term effects of HI PEC depend in any way on the chemical agent used in HI PEC? So is it a different answer for melphalan versus mitomycin C? But let's just start with that to kind of mitigate some of those or assuage some of those concerns or validate, depending on what your thoughts are.
All right, I think there's several points you left on. Are there long-term side effects of HI PEC? And yes, there can be. This can be a life-changing operation. It depends upon what needs to be done, and what's going to determine that is what the volume of disease is, whether it's low grade or high grade, and are there complications which are going to ensue after the operation is done. In terms of, are there different side effects specifically for the perfusate or what the chemotherapy is, the answer is yes. In the randomized trial, we found that the patients who had oxaliplatin had a slightly better quality of life over the course of the first 3 to 6 months. Beyond that, it didn't make any difference as far as I can tell, at least not by using the research tools that we use it. The real long-term side effects are going to come from adverse events. So if there's where you sew the bowel together, if it doesn't heal up properly, if you need a colostomy, if you have a wound infection, you develop a hernia, all of those things can have long-term side effects. Specifically, in terms of neuropathy or neurologic issues, there are very few related to the chemotherapy per se. Much of the neuropathy that you might see with something like oxaliplatin therapy really doesn't apply to the HI PEC because you're giving it as a single dose, single time. So you don't see the long-term side effects in general. Now, if you already have neuropathy from oxaliplatin to begin with and you get another dose, can it make it worse? Absolutely. Is that to make it a permanent thing? Not necessarily. I don't think it's particularly worse than the neuropathy you get from an intravenous dose as far as I can tell. And I think I'm giving a long answer to your short question.
No, it was a long question. It was achieving 2-3 questions in one. Dr. Zhang or Turaga, do you have anything else to add, or Dr. Lambert? If not, I can move on to another HI PEC question.
Well, Deborah, I was going to say it depends. Like you had
Okay.
said,
That's
but,
fair answer.
And just really echoing what Dr. Levine was saying was that it really just is depending on the magnitude of the operation, what's done during the operation. Remember, the cytoreduction is separate from the HI PEC in that each is associated with its own set of complications, dependent on the degree and magnitude of operation and amount of disease that there is. Certainly with different methods of chemoperfusion, cisplatin has a non-trivial rate of kidney injury, although again, I think in our experiences at these high volume centers, these are more self-limiting and often resolve, but that is certainly something that is to take in consideration when you're utilizing different forms of chemoperfusion. So I do think we do have to be mindful of some of these potential toxicities and side effects, but certainly we do find that patients tolerate this because again, it's a one-time thing, much better than systemic therapy that's over the course of months.
And I see Dr. Turaga's hand up, and Dr. Turaga, I want you to of course respond, but also I'm going to cheat and ask one more HI PEC question, and maybe you can lead with that. And then I want to give the wheel to Dr. Lambert because I'm sure she has some live questions. But speaking about HI PEC, how is the agent to be used in HI PEC determined? So we see a lot of mitomycin C, not always. So from your standpoint, like, what is the thinking behind what you choose? And, you know, we heard earlier about with organoids, we can maybe drill down and see what might be more effective, but what is the current state of play? What is the thinking? So.
Thanks, Deborah, for that. In fact, I raised my hand just to say that we should probably get the opinion from Dr. Lambert, because I do think, HI PEC as a long-term event, cytoreduction and HI PEC. I think it's easy for us as physicians to kind of think about sort of that short spectrum of 3-6 months of follow-up and recovery. And I know we all follow patients for a long time, but I think these are, pretty traumatic events overall. And I do think, Ed's group has done a really nice job of sort of looking at quality of life long-term. But I think the concept of survivorship is something that we do need to embrace within our field more. Which I think actually Dr. Lambert is probably uniquely qualified to, because she certainly has a strong interest in that. To your question though, Deborah, about the agent choice, I think Dr. Levine's big randomized trial, the only randomized trial for appendix cancer, did show relative sort of equivalence between mitomycin and oxaliplatin. From the colorectal literature, there's short duration, high dose oxaliplatin doesn't work very well. So I do think mitomycin still is one of the good agents for intraperitoneal chemotherapy as it stands today. But I think in terms of the future, it's incredible. I mean, I think that's really what the symposium is about, is how do we highlight, better advances, either using organoids or using other ways of identifying, sensitivities of these tumors to agents, and then also delivering agents maybe in a different way, like PIPEC, or maybe, could you even put immunotherapy intraperitoneally? Could you do other CAR T cells intraperitoneally? Could you inject STING agonists intraperitoneally? So I think the whole world is open to us right now. And I think really that's where patients, ACPMP and treating teams like ourselves, we all have to get together to build up on this and build new trials. But I'd be very curious to hear Dr. Lambert's opinion on the survivorship part.
Thanks, Dr. Turaga. I have to agree with everything that you guys have said. And I just can't imagine how going through this surgery cannot be a life-altering event, even if it is successful, even if you recover back to better quality of life, like some of Dr. Levine's studies have shown, by 3 to 6 months after the surgery. It's still a major, it's just, there really isn't a surgery that's quite like this, right? You come out with a scar, often from the breastbone to the pubic symphysis, and major organs have been resected, multiple of them, and then you've had heated chemotherapy, put in the abdomen. I think there's not quite anything like it, and I am so impressed and humbled by the people who trust us to provide this for them, and watch them with the grace and strength and dignity that they go through this for the motivation that they have, right, to live longer and spend more time with their families and their loved ones and accomplish things. And there's been some comments in the question that people have been putting in about how they're 20-year survivors, and and they're still coming to a symposium like this to learn more and to support other people. So without a doubt, it's something that nobody would ask to have put on their plate in life, and yet here are people that are coming out to support those who are earlier on their journey with this cancer, and rally around each other as a community, and to provide hope. And that's, you're exactly right. And that's what I love about being a part of this community as a surgical oncologist, and all of you who are my colleagues, and those of us, the rest in the HI PEC community, who are really just sort of dedicated to making this better. It's quite an honor to be a part of this community. So thank you. But there is kind of a little bit of a follow-up question on this topic as well from the live chat. It was in regards to side effects. What do you guys think about the different side effects between just normothermic IP chemotherapy and HI PEC? Are there side effects of the hyperthermia itself?
Ed, do you want to speak about that, or?
I haven't done a great deal of normothermic perfusions, to be totally honest. I tend to doubt there would be, but it's going to depend upon what your temperature is. Here at Wake Forest, we run 40 degrees at the outflow cannula. That's about 105. Once you start getting over 43, 44 degrees, you can have basically irritation of the peritoneum or peritonitis. There's a hyperthermic pancreatitis you can get. You have to be careful in terms of what the temperatures are. Mm-hmm. But in terms of the side effects likely to be experienced by patients, I'm not sure it's going to make a whole lot of difference up to that temperature range. If you're really, and there are centers which have really pushed the temperature. I don't know that any of them are represented on this call, but I don't know that the patient's going to experience a whole lot if you're perfusing at 37 or 40 degrees.
Yeah. Dr. Turaga or Dr. Eng, in your experience with the iterative HI PECs that are at the normal temperature, or they're HI PECs rather, iterative HI PECs, have you seen anything specific about those side effect wise?
I think patients have generally tolerated it pretty well. We've done, iterative HI PECs with the high-grade appendix patients with mitomycin, and then with the gastric patients with cisplatin and mitomycin, and overall they do tolerate it pretty well, but I do think some of them do have some chronic pain from perhaps some inflammation along the peritoneum over time. When they get to that sort of third or fourth one, they get a lot more sort of pain along the incisions in the anterior abdomen. But I think overall our patients have tolerated it pretty well. And I think the key to it is also not just us, it's the nursing protocols and the team that we have in the operating room that helps mitigate these issues. When we start cooling the patients, when we're anticipating we're going to induce, hyperthermia. I mean, these are all things that every sort of piece of the puzzle matters just as much. And I think when you're at an institution that does it a lot, like all 3 of ours, you have these streamlined protocols, which make a huge difference.
Just to add to that, though, one of the very interesting things for me is when we separated the cytoreduction from the HI PEC. We always have this sort of fear that, oh my God, HI PEC is such a toxic delivery of intraperitoneal chemo. There's hyperthermia, there's chemotherapy, there's perfusion, there's flow. And so how would patients do? And, early on when we started doing this iterative HI PEC, we kept patients in the hospital. We were worried about their bowel function and this and that. And, we got to COVID and we wanted to get patients out of the hospital. Patients were feeling pretty good. And we started discharging everyone day 0. And I would say that, certainly patients have some side effects with, the intraperitoneal chemo part of it, but it's very, very minimal. I would say it's very low compared to even IV chemotherapy. And so I've been very impressed with the tolerability of intraperitoneal HI PEC. And I think that's also very similarly mirrored in sort of the PIPEC trials where, patients are being sent home the same day. So I think the delivery of intraperitoneal chemo seems to be pretty well tolerated overall. And I think the sort of big, concern about it, I think is more. I think it's just when it's additive to a big cytoreductive surgery, that's when I think we worry a little bit more about the morbidity. But I don't know what Ed or Laura, I don't know what you guys think about it.
Ed?
I think you're absolutely right. Just a couple of things I wanted to echo is I think Oliver put forth nursing team and nursing support, having that kind of support and experienced teams, not just the surgeon, but the whole hospital system makes a big difference. And again, the vast majority of the toxicity is going to be from the cytoreduction without question. I mean, it's not the intraperitoneal chemotherapy, it's what the surgery represents. Because, some of these operations, you can remove all or parts of 10 different organs in the abdomen. That is an enormous impact on patients, even if things heal up very, very well. Whereas if you do some of just a perfusion as an outpatient, just running the chemo around is actually remarkably well tolerated.
Yeah, I would agree with all of that. Absolutely. I guess we do know from the ovarian data that the the normothermic intraperitoneal chemotherapy that's given as part of the treatment with systemic chemotherapy, the bidirectional, can have its challenges, and some of those regimens can be a little bit difficult. But again, these either the iterative HI PEC or the one-time HI PEC, I agree. It's really the cytoreduction with the HI PEC that I think causes the most side effects, if you will. Mm-hmm.
Okay, great. So if you see my eyes shifting all over, I need new glasses and I'm just looking. So we have 17 minutes. I know that Lauren's doing a great job as taskmaster, keeping us all on track. One additional question kind of from the treatment surgical side, and then maybe Dr. Lambert, we could switch into sort of post-treatment surveillance type questions. Something that I know you all don't want to see, patients, caregivers never want to see, but it's a reality. And that is, we get a lot of questions about aborted surgeries, aborted CRS HI PECs, and what goes into a decision to abort. And then perhaps just as important, if not more importantly, what is advisable for those patients then that end up to not be eligible for CRS HI PEC? What are some options for them? I think we heard a lot about great research going on, and maybe that's the answer. We've got our standard chemo and there's research, but Any thoughts you have on that? One, as surgeons, what goes into a decision to abort? And then two, what is the recommendation for those patients or patients that didn't even get as far as the OR? There's already a decision that they're not going to be eligible at that time for CRS HIPEC. Tough situation.
Yeah, maybe I'll start it off, and I think it'd be nice to hear everyone's thoughts. I think the decision for HIPEC, or actually cytoreduction in HIPEC, it's a complex decision, just like any other medical decision, and it actually starts in the clinic. It starts when you see each other in clinic. It depends on the patient, their goals, what cancer they have, how they feel and look, and then of course how we believe the disease is going to do. I think the skill of the surgeon is important. I know you've heard this a million times over, but in appendix cancer surgery, we do know that if the prior surgical score is high, which means if other surgeons have operated before, it makes it very difficult to go back into surgery. If you look at Dr. Levine had one of the slides, do not open planes. That makes it difficult for us to do cytoreductions again. So it is important that when you select your treating team, you're selecting a team that knows what they're doing. And then finally, the judgment intraoperatively, is dependent on a few factors. Again, it depends on how the patient is doing. If the patient's not doing so well, that could change the nature of the operation. The findings that we find during surgery, which could include a higher burden of cancer than expected. Usually the biggest thing that prevents us from doing a complete cytoreduction is sort of this cancer that engulfs the blood supply of the intestines, called the mesentery, as it goes up onto the intestinal surfaces. And that's a little difficult to take out. But the judgment, and I can tell you this from my own experience, my own judgment has evolved over the last 2 decades. And so what I thought I could not do before, I can do now technically. What I thought I should do, I don't do now. So I do think that experience is, it comes from all the mistakes we've made or all the lessons we've learned. And so I do think it's very important. And in fact, whenever we abort a procedure at University of Chicago, it's very common practice for me to call my partner, so Dr. Eng, to say, hey, we're going to stop doing this operation. Is this okay? Like, it's not that I'm not doing this because, some other extraneous factor is interfering. Is this a fair thing to do? Because we realize that, aborting a procedure like this has a very difficult prognosis for patients afterwards. I think the challenge for patients, even though we're talking about all the exciting things today at our symposium, the biggest challenge is that a lot of these diseases are not well measured on imaging. And so it's very difficult to refer these patients for clinical trials. So yes, there could be all these advances in immunotherapy and, KRAS mutations and everything else. But the reality of the matter is we can't see it. And so that's why it is important that, as an organization, we advocate for our patients to be eligible for these clinical trials. We do have to advocate for patients, especially with visual confirmation of disease, that we can get them on clinical trials and have alternative surrogates for response. So I think the bottom line answer, I would say many factors that determine it. Experience of the team really, really matters. And I do think that, the bowel surfaces are usually the limiting factor for surgery.
Great. So I'm looking at time. We have still a few minutes. I do want to get to some imaging questions. Dr. Lambert, you probably have live questions, but does anyone want a quick like 30-second add on to what Dr. Turaga just said, or can we move on?
I'll put in a couple of things. I think in terms of aborting these procedures, I'll tell you that is, and I can tell you for the surgeons who are on this call, that is our least favorite operation. Nobody wants to do that. We do a lot of things to minimize that with quality imaging. You can minimize the risk. Sometimes the preoperative laparoscopy can help somewhat, but even that's not 100% predictive. So you want to avoid that if you can. It's really a non-therapeutic laparotomy. So when you say aborted, it depends on where you're at, and it depends on what tumor grade it is. Now, we're just talking about appendix here. The rules are different if you're talking about HIPECs for gastric cancer, colon cancer, that sort of thing. For a low-grade tumor, I'm going to persist and try to reduce everyone as much as I possibly can, because there really is no meaningful medical therapy for it. There's promising things on the horizon, yes, but there really isn't a whole lot in the way of chemotherapy. So I'll push surgery as far as I can. For higher grade tumors, I'm going to use the same sort of PCI cutoff I use for colon cancers. Because once you get beyond a PCI of 15 or 20 for a really high grade appendiceal cancer, even if you can try to reduce them, the outcomes are really not very good. And the morbidity to be paid for high PCI cytoreductions is high. So again, this is one of those judgments you have to make. Unfortunately, a lot of those judgments are learned at the expense of patients who have suffered because we persisted when we shouldn't have. And I think Dr. Turaga hit the point exactly right on. The difference between an experienced HI-PEC surgeon and an inexperienced one. Push the technical aspects and attributes as far as you can when you need them. And when you find something where even if you have a technical feat that you can peel something off of something, it may not be the right, just because you can doesn't mean you should. Mm-hmm. And that's exactly the kind of judgment you need to have your surgeon to have for you.
Oh, yeah. Dr. Lambert, were you going to say something or?
No, just agreeing.
Great.
You know, Ed is, I think, a few years ahead of Kiran and I, and we're a few years ahead of Oliver, and we can all appreciate what everybody else is saying.
Great. So I thought we could switch into some of the post-treatment surveillance, but I also, Dr. Lambert, I don't know if you've got any live questions that you want to bring in, or?
No, I think this would be a good time to transition to that.
Okay, great. So trying to distill the questions that we get about imaging to kind of bucket up into one huge question. And I'm sure, Dr. Lambert, you're doing the same with your lives, but basically, so many questions we get about what is the preferred imaging for post-treatment surveillance? What is the protocol? So what type of imaging, at what sort of intervals are we talking about? Does the answer, again, Dr. Ng, just it depends? I mean, we see so many patients getting so many different recommendations and don't know, is there a best practice, or how should patients think about it? And last but not least, is there a sort of milestone where patients can now kind of relax a little bit in terms of worrying about a recurrence? So imaging surveillance, what type, at what intervals, and are there certain milestones where maybe a little sigh of relief can be had?
Dr. Ng, it depends.
Yeah, well, I mean, it does in a way, and you know, it obviously depends on many factors, which include the biology of disease, the burden of disease, and the timeline of everything. And so I think, you know, unfortunately, I am being vague because it depends on all these different aspects of the patient's recovery period and disease process and so forth. You know, I think, as Dr. Harmath had outlined, there are different advantages and disadvantages of CAT scans and MRIs. And there's also the practical aspect of, you know, where can you get an MRI that is of the quality that you expect, and also sort of the distance that patients have to travel to get that. And, you know, CT itself is much more feasible and more readily reproducible and a lot quicker for a patient to undergo. I've had many patients who we want to get an MRI on, and they say, well, you know, I don't want to be in an MRI for this duration of time because I just can't tolerate it. And, you know, is that okay? And, you know, of course it's okay. And so, you know, I would say that with this disease process, regardless of what we do in many instances, I mean, the recurrence rate is high. Now, the time at which it occurs depends on the biology of disease. But that being said, we watch patients closely. You know, we get a post surgery imaging usually anywhere between 6 to 8 weeks, and then depending on whether or not they get chemotherapy afterwards or surveillance, you know, typically imaging is every 3 months for the first year or two, and then we start to space it out after that to maybe every 6 months and every year after that. But at the same time, it really just depends on the disease process and the patient.
I think I would just, and maybe you guys know something that I don't know, but I'm not aware of any study that says MRI detects tumor or recurrence early enough before CT scan that it will make a difference in the oncologic outcome, right? And so I know, but there are concerns, you know, I think a lot of people, especially young people who are going to be looking at long-term surveillance with CT scans, have concerns about radiation. I think we share some concerns about MRI. I know I do, just because I can't read them as well myself, and I could read CT scans much better. But if you have a very good MRIist and a protocol, somebody that you trust, then it's a very good option, and it can pick up certain things better than CT scan. But do you guys know of any, or do you believe that using MRI over CT or vice versa is going to detect something early enough that it's actually going to impact something oncologically?
For what it's worthwhile, I'm going to tend to agree with you. I still prefer CT scans for several reasons. Number one, they're more widely available. Like you, I'm much better reading as a CT scan than I am for an MR. And what it is true that there's research data that shows that MRs are slightly, and I mean slightly, more sensitive to small volume lesions. But when you're talking about following somebody for recurrence after a HI PEC, you're not looking for subtle changes. And there's been so much surgery with most of these, there's going to be subtle changes in the peritoneum all the time. And one of the reasons we never get post-resection HI PECs for months, because there's so much inflammation, residual fluid. I don't know what it is and how to interpret it. So usually most of these patients for low grade, I wouldn't bother following anybody more often than every 6 months. For high grade, you can make an argument for 3 to 6 months, if and only if it's going to change your chemotherapy. And I would keep in mind that in general, if your tumor recurs very quickly, you're going to probably go on chemotherapy for some time anyway. There's data from us and other centers which has shown that if you have to repeat the HI PEC in less than a year, the outcomes tend to be quite poor. Mm-hmm. So there's not a reason to look for really subtle, maybe ifsy, whatsy lesions. It's going to be very hard to put a laparoscope in there and to go back in there and biopsy it again. The best test remains the test of time, although that's the hardest on the patient's nervous system. There's no question about it.
Yeah. Good. And then Dr. Hay had done a presentation on this, but we did get some questions ahead, and maybe for those that missed that, we do have patients that prefer to rely on the circulating DNA test for surveillance rather than imaging. Given the current state of play with the circulating DNA tests, it sounds, I mean, my takeaway was that we're just unfortunately not to the state where that has really good, solid predictive value yet, but there's research going on. What do any of you all follow your patients just with the circulating DNA test? I mean, what do you think about that?
I think, I can share some of our experiences. So we've obviously been very interested in following our patients with circulating tumor DNA for two reasons. One, obviously, can we detect recurrences early? But then more importantly, can we actually then sequence those to identify mutational changes? Can we then understand what's happening to this disease over time? And so preliminarily, what we've found, which is actually which is actually an interesting observation, is that even patients who have low-grade carcinoma peritonei from the Lamens or the DPAM from the Ronnet classification, even they shed more DNA in their plasma than normal controls, than healthy people. So even though we know that these diseases stay in the peritoneum, they don't spread outside. So we do see that, but that is only detectable at very, very small levels, at nanogram levels. The high-grade patients, they do shed much more circulating tumor DNA. We've been using a colon cancer test called Signatera, which is similar to sort of another test called Garden, which people use. But we've been using that in a serial fashion to track patients, perhaps more from like an interest and academic standpoint than maybe as a clinically relevant standpoint, because like you said, Deborah, we don't know what to do with that information. So I'll give you a classic example of, how this conundrum creates, or how this test creates a conundrum, which is this test basically detects DNA in the blood. And so let's say we have a patient with high-grade cancer and we're getting this along with the CT scans and tumor markers every 3 months or every 6 months. And we've had some patients in whom it turns positive, but we have no other cancer anywhere else. And I think to Ed's point, do we do a laparoscopy? It's already a difficult laparoscopy. Do we give them chemotherapy? Do we just keep waiting? And the answer has been to keep waiting. And in fact, we've had some patients in whom a positive test turned negative and a negative test, turned positive. And so it's a little variable. We've found, at least in our preliminary analysis, we have an abstract coming up to SSO, but basically only about 56% of our patients with detectable cancer have a positive cell-free DNA in commercial tests like Signatera. So I think the jury is out. I don't think any of us could confidently tell you, yes, this is the best test to do. I do think we do it. I do think it creates anxiety for my patients, 100%. I think it creates anxiety for our teams. But we're hoping that we can maybe unlock something for the future and maybe then give patients access to trials. Because I feel like without imageable disease, we're just struggling to put anyone on trials. And I'm hoping this could be one modality to get there.
Okay, I'm looking, thank you for that. Now we're I have right at 2:45 Eastern. So Dr. Lambert, do you have anything to close us out?
No, I just want to thank the panel and thank Dr. Levine, Dr. Turaga for co-organizing the event with ACPMP and Huntsman. And I think I feel like it's been a great symposium. I learned a lot as well. So I appreciate everybody's efforts and hope we have good regional symposium experiences as well. So,
and thank you for everything that you all are doing.
And thank you, Dr. Eng, for joining the panel too.
Great.
Of course.
Thanks, everyone.
Thank you guys so much for that wonderful session and for taking the time out of your busy schedules to come on and answer some questions. I also want to thank Deborah Shelton with ACPMP for helping moderate with Dr. Lambert. So that kind of concludes our general session for this afternoon. We are now going to take, I think, about 15-minute break before we launch into the 3 regional sessions that are going to be hosted by each of the institutions. So Wake Forest, Huntsman, and the University of Chicago. Those links are in the chat, but you will have also received them to your email. If we didn't get to your questions today, please note that we did get all of them in the Q&A and we will have a full report. So we'll try and answer those and maybe send some recap emails if possible. The recordings for this general session and for all of the regional sessions will be available at acpmp.org/Symposium 2021. We will also circulate the links to the recordings on our ACPMP Facebook page too. Again, I just want to take the time to say a great big thank you to all of our speakers today that came on, speakers from all 3 institutions, but also from other institutions that made guest appearances. And I look forward to having everyone participate in our regional sessions. Thank you on behalf of the ACPMP Research Foundation, and see you soon.